Vikramveer.
Hello, good evening, sir. Myself, Dr. Vikramveer, welcoming you all for this Aarcon first show. आप तमाम बंदा परवर का मैं विक्रमवीर तहे दिल से स्वागत करता हूँ। सर, प्लीज चेयरपर्सन साहब, सर, डॉक्टर सुरेंद्र प्रसाद गुप्ता सर, प्लीज कम ऑन चेयर सर. डॉक्टर अनूप कुमार सर, सर प्लीज. डॉक्टर कर्नल संतोष कुमार सिंह सर, and Dr. Firoz Alam sir, please come. And now I would like to request Dr. Gurudev, the arthroscopic rock star, please come.
But it cannot be completely stop the disease. It only delayed the progression of the disease. So where the synovectomy can be preferred, it can be done in the shoulder, elbow, wrist, and knee. Here I am discussing about the knee of the synovectomy only. There are certain portal. So how it is done? So basically it done by 6 portal, 2 extender anteromedial, anterolateral, posteromedial, posterolateral, and sometimes superolateral and superomedial portal. The sequence or the area where to look for synovectomy, it is the intercondylar notch, posterolateral compartment, posteromedial compartment, medial compartment, lateral compartment, suprapatellar pouch, retropatellar area, and under surface of each meniscus is carefully examined. Sometimes it is located there also, and if there is popliteal cyst, foreign body, and the plica which should be removed, and use of radiofrequency ablation to minimize the bleeding, because this joint is highly inflamed and there is very high chance of bleeding after the surgery. Put the drain and apply the compression bandage. This is the quick video I am showing here how I do the arthroscopic synovectomy. Sir has given this topic, so there is not good video, but this is one case I have done. So in the intercondylar notch, after doing the synovectomy in the medial compartment and making the space between ACL and PCL to enter the posterior compartment of the knee joint, then doing in the suprapatellar pouch, removing all the synovium in the lateral and the medial side, and up to the tendon, quadriceps tendon proximally, and then come to the retropatellar area, and this is the anterior most part of the knee joint where some amount of synovium is lying there. So to remove as much as visible during the arthroscopy. And this joint is highly vascular. So many times post-operative, within 3 to 4 hours, there is a lot of bleeding, soakage. So always at the time of this kind of patient, we use the radiofrequency ablation to curate the bleeding point. We can shown you here this radiofrequency ablation, and this is the posteromedial compartment at the final stage of the synovectomy. removing the intermuscular septum and do both medial and lateral. And this is the final picture after doing the total sanobectomy of the knee joint. So what are the advantage of doing arthroscopic sanobectomy? There is significant improvement in the pain score, reduction of the disease in the joint can be managed with the single disease modifying rheumatoid drug. Most accurate diagnosis via synovial biopsy and synovial fluid analysis, nearly complete removal of the synovium under visualization, and there is diminution of the joint stiffness post-surgery and short hospital stay. The post-operative care is drain should be removed after 48 hours. Static quadriceps and passive range of motion started in immediate post-op period. Post-operative rehab protocol for quadriceps and hamstring strengthening exercise, active range of motion, and modality to decrease pain, swelling, stiffness in the post-operative period. Thank you.
Thank you, Dr. Gurudev. Now I'll invite question and discussion at a later stage. Now I'll invite Dr.
Thank you.
Gurudev, Dr. Arvind Prasad Gupta for a talk on reverse shoulder arthroplasty in rheumatoid arthritis patient.
Good evening to all. So I'll be presenting reverse shoulder arthroplasty in rheumatoid arthritis. So we all know this Yes. Okay. So this rheumatoid arthritis involve almost every part of the joints of the body. So after hip and knee and hand joints, the shoulder joint is the most common joints involved. So I'll start with this case. She is 65-year female. So Dr. Santosh. Yeah.
First,
Yes.
go for markers and all.
Yeah.
What are the reason for?
Yeah, perfect.
Yes.
So start with all these markers and confirm the diagnosis. But this is very characteristic picture of any inflammatory type of arthritis of the joint. Particularly if shoulder joint get involved, you will have lot of bone erosion. Either it's in the hip or knee or the shoulder. You'll find there is lot of bone erosion is there. At the same time, we will have osteoporosis. And most of the time, patient present very late. They started with anti-rheumatoid treatment and then keep going with that and then present with such type of picture to us. So similarly, in literature it says almost 50 to 90% of the rheumatoid patient will have some kind of involvement of the shoulder joint. But because of recent DMR and treatment, this incidence has reduced, but still it is one of the joint that get involved. And of course, the other side of this disease that this came very late with severe pathological changes. So at this stage, most of the time you will have treatment option in form of either total shoulder replacement or reverse shoulder replacement. So reverse shoulder replacement is the new one. This patient came to me almost 2 years back, very young patient. You can see it's 28-year-old only. And severe rheumatoid patient with almost involvement of the shoulder joint, and hardly there is any movement of this. And this was the right side, I think, right shoulder of this patient, hardly doing any activity with this. So he came for the treatment, and considering the age, that patient was treated with the total shoulder arthroplasty only. But result with this, because rheumatoid involve your cuff also, along with the bone there is involvement of the cuff. And the integrity of the cuff is important for your mobilization, movement of your shoulder joint. So patient is not very satisfied, and this all also gets supported with lot of literature that doing total shoulder replacement in rheumatoid or any inflammatory arthritis will not give very wonderful result like reverse shoulder. So if you see the biomechanics of this shoulder joint, so initially it's abducted by the cuff, then followed by this deltoid came into the action. So the concept of reverse shoulder orthoplasty developed, in which the center of rotation of the humeral head get medialized. You can see here from here to here, and as well as it get inferioralized. So center of rotation get changed. That leads to change in the moment arc of the your force. That deltoid direction has changed full little bit. At the same time length get changed. So from very beginning your deltoid act as a abductor of your shoulder joint. That is in the reverse shoulder arthroplasty. So you don't need to have cuff for initial abduction of 20 to 30 degree. So once deltoid start acting, so it's start getting abduction from 0 degree. So length also get increased, so force for the abduction is also get increased. And this is how this is anatomic one. Pointer hai. So this is how you can see the anatomic one, the center of rotation where it's lie. And you can see the reverse shoulder orthoplasty where center of rotation lie. It's inferior and medial. And then there was some problem with that in form of this was 155 degree, but because of notching was there, so this gets changed to 145 degree, and because of it was too medialized, so later on there was little bit lateralized glenoid came, and this is how later on this lateralized glenoid prevent the chances of notching in this reverse shoulder orthoplasty. So coming back to this patient, so since the age was 65 and there was almost loss of, you can see there is hardly any cuff in this case, and there was complete loss of the bone was there. So of course total shoulder orthoplasty will not going to work in this case, and this is how this intra picture looks. So this patient was treated with the reverse shoulder orthoplasty. And this was in the follow-up, and this was the clinical picture of this patient. So you can see she can have almost full abduction without any support, initial abduction support, full external rotation. You can see the external rotation in 90 degree of abduction. That is one of the most important function for the overhead activity. And of course, since the subscap is almost non-working in reverse shoulder orthoplasty, so there will be deficit of internal rotation. It never be complete. So this was the clinical picture. This was another patient of 70-year female, almost hand, knee. She was already operated for the knee, and then bilateral shoulder problem was there. So this is how this axillary view you can see. And this is how your cuff condition looks like. So it's almost degenerated. Along with the involvement of the bone, there will be involvement of the cuff, there will be involvement of the AC joint in this inflammatory arthritis. So again, this patient was treated with the reverse shoulder orthoplasty. So if you see the literature, so recent literature almost in 2023 compare this reverse with the total and says all these inflammatory arthritis having better benefit with the reverse shoulder orthoplasty. Another paper is systemic review, again this reverse shoulder orthoplasty having higher age in the treatment of replacement. Another survival and outcome, Journal of Shoulder and the Elbow Surgery, it says it's safe and effective procedure for the treatment of rheumatoid arthritis with a low risk of complication and low rate of revision in comparison of total shoulder, because the glenoid part loss in the total shoulder is early because of osteoporosis and the bone loss with total shoulder. That is not too much with the reverse shoulder. With all these, I am inviting you all for 34th COE. The theme is fracture around the knee joint. That date is 28 to 29 December. Thank you.
Thank you, Dr. Arvind. Nice presentation. Next, I would like to invite Dr. Abhishek Das. He'll be talking on shoulder hemiarthroplasty in rheumatoid arthritis.
Good evening, everybody. I would like to congratulate Dr. Amulya sir and his team for such a nice conference on a separate theme, which we orthopedic surgeons are not very well versed. And I'm hoping to learn something in the next 2 days. And also like to thank him for this opportunity to present this talk. So, hemiarthroplasty is not something that I do very often, but this is something which should be in our armamentarium as a surgeon, especially in India, where not everybody can afford reverse shoulder arthroplasty, though affordability should not be a criteria for treatment. That is my firm belief. Now, looking at the pathogenesis, which we'll all learn more about in the next sessions, there is usually a pannus formation, which then eats into the joint from the periphery, then subacromial bursitis leading to rotator cuff involvement and arthritis. Now, this lane classification is an old one proposed in 1950s and still is valid to certain extent, though I do not really use it for deciding management, but still from theoretical perspective, stage 1 is where there is slight tenderness and limitation of range of movement with negative X-ray findings. Stage 2 is where there is marked limitation of range of movement with tenderness and radiographic findings of erosion of joint space. And finally, there is a burnt out disease, severe limitation with complete loss of joint space. So it is mainly stage 2 and 3 where we need to do something about it. However, with improved and early diagnosis, DMARDs and biological and the newer agents have reduced and potentially delayed the need for surgical intervention in rheumatoid arthritis as a whole, but rheumatoid shoulder and upper limb rheumatoid arthritis where they are non-weight bearing joints. So my first case, this was done in when I was in England about 7 years ago, 41-year-old chap, a bit unusual because of common use of biologicals. He still had multiple joint involvement, debilitating shoulder pain, night pain, severe functional limitation on DMARDs and biological agent. Intra-articular injections were performed twice. Still, he didn't have much relief. He was a heavy goods vehicle driver. So the question is, what do we do with his X-rays and with this clinical picture? So he does seem to have a global involvement and arthritis. So this is what we did. So this was a short stem hemiarthroplasty, and if you look very closely, can anybody identify what is the difference between this hemiarthroplasty and the arthroplasty that we regularly do? So because he was 41, we chose to do something which was unique. So he has a pyrocarbon head on this hemiarthroplasty, and pyrocarbon is a material which is slightly on the costlier side, but it has coefficient of hardness which is very close to the bone, so it doesn't kind of grind into the glenoid. So it is designed for young patients where you can do hemiarthroplasty where the coefficient of hardness matches the bone so that it can last longer. I would still believe that 40-year-olds are not technically the best patients for reverse shoulder arthroplasty because the long-term data is still awaited. This is a case 2 which was done about a year and a half ago. 58-year-old inspector by profession, long-standing rheumatoid arthritis, well managed on DMARDs with good pain relief, minimal functional limitation, fall while running on duty, and bilateral shoulder fracture. So nothing much needs to be said about the right side, did a fixation, but the left side. So left side is, I think everybody will agree, is irreconstructible proximal humerus fracture. This is what we did. Now, this is up for challenges and for argument. Personally, I would have liked to do something better than this, which is available, but we have some challenges in the part of the world where we are, that reverse shoulders are still not stocked in Patna, and the patient was not willing to wait for 5 days for everything to arrive. Having said that, I am proud of this fixation because tuberosities stand where they are, and he still has a reasonably good movement. He still had 3 years to retire, and he's gone back to his work. Shoulder movement still around 100 degrees of abduction and forward flexion, but it is pain-free. And I saw him about 6 months ago, still doing well, but long-term results needs to be seen. So some literature. So what does the literature say about the hemiarthroplasty in treatment of rheumatoid shoulder. So we can see that this is an old article, patient selection 94 to 2004, when the reverses were developing. So they had good results with hemiarthroplasty. However, you can see the mean abduction was less than 90 degree in this. Now the next paper, which says long-term results of shoulder hemiarthroplasty. Now again, when they say long-term results, this is not so long ago paper, and what we see is that the mean follow-up was 10 years. Mean implant survival rate is still debatable. It's only about 4 to 5 years. So in essence, what are my indications? Where do I prefer hemiarthroplasty, if at all I do it? Young patients with severe debilitating shoulder rheumatoid arthritis. Young, we need to define based on our practice. Cases are decreasing due to fantastic results of newer therapy. Cost effectiveness, definitely it is almost 1/3 of the price of what we get reverses. So we need to think in our context, in our perspective, and where we practice. Availability of implants, still reverses getting available same day, next day is a challenge here in Patna. I still feel that it has a role in trauma cases with pre-existing rheumatoid arthritis, and in all these cases, potentially intra-op decision is the best, where you look at the rotator cuff and you decide for yourself whether you want to do a hemi or a reverse shoulder arthroplasty. Role of shoulder hemiarthroplasty in rheumatoid arthritis is limited. Proper patient and implant selection is paramount to success of surgery, and appropriate patient counseling regarding functional outcome is very, very important. Thank you.
Any question?
Can we have all the three
Any
speakers?
questions from the
all
audience?
The three speakers on the dais, please.
All three speakers come to the dais. Any question from audience? No
I
question.
have a question for Dr. Arvind. So when you do a reverse shoulder arthroplasty in rheumatoid and inflammatory cases, what is your stem selection? I mean, do you at all prefer a stemless reverse shoulder, or a small or a long stem?
So my preferred choice is the cemented one. It's never uncemented. That is the first one. About the short stem and long stem, if you are talking about, so we have availability of a standard stem most of the time here. So I use that. So the concept behind choosing the cemented one, most of the time these inflammatory patients very high in the stage. At the same time, bone, if you see all the 3-4 cases that I have shown, almost it's the papery thin bone it was. So fixing with uncemented stem becomes sometimes difficult. So this my preferred choice is cemented one.
My question from the Dr. Gurudev: what precaution we should take in doing the arthroscopy in the rheumatoid patient in comparison to the normal knee arthritic patient?
It's a good one, boss. Because in rheumatoid patient, basically I am talking about the knee only, and of course shoulder also. So the bone quality is very, very poor. So in that situation, first at the time of insertion of the trocar and cannula, be little gentle and don't penetrate when it is not going, there is some obstruction. So don't put the force, apply force while inserting the trocar and cannula, otherwise it may break the condyle or the cartilage. So this is the first and most important precaution while doing the joint lavage in rheumatoid patient.
Can you use some corticosteroids for relief of pain during the after completing the operation, locally joint? Can you infuse some amount of corticosteroids?
No, yes, at the end of doing the joint lavage, we insert the corticosteroid not on the same day at the time of discharge of the patient, both in the shoulder and in the knee joint. Nowadays, this joint lavage is in European country, it is not limited to the orthopedic surgeon. It can be done by the rheumatologist also. And it is a daycare procedure under the local anesthesia with the mini scope. So it is not limited to the orthopedic surgeon. It can be done by the rheumatologist also, and the daycare procedure under local anesthesia.
One question from Dr. Abhishek. What percentage of cases you consider the most debilitating disease in young patients? What percentage? Because it has started in 20 and 30 years.
Yeah.
So up to 40 years, how many persons are involved?
So
in
my
your
experience with rheumatoid arthritis and inflammatory arthritis is that there are two kinds. I'll still have to look at the paper, but one is a painful one, other is a deforming one. So we'll have to look at the other speakers, what they have thoughts on this. But the painful ones are the ones who are managed very well with the biologicals and the DMARDs, whereas the deforming ones, they do have a tremendous amount of deformity, especially the small joints of the fingers, where we used to spend the whole list just correcting the deformity of the hands when I did my hand post in the UK. With regards to the shoulder, younger patients are decreasing. The amount of deformity and the need for hemiarthroplasty thus has decreased tremendously over the last 10 years. I would say only 1 in 10 patient would be the one who would be less than 45, would come to you where you would say, well, now the time is up for joint saving surgery. We need to do something where we need to replace the joint. So the numbers have decreased, but I cannot quote a figure, exactly.
Apart from biological agent, can you use local corticosteroid before going to surgery? How many bots of intraarticular injection?
Any joint, whether it is inflammatory or whether it is in elderly, if an injection has been given in the joint, I would like to reserve any kind of surgery for after 3 months. So 3 months the joint should be virgin because it increases the risk of infection. That was the practice in UK, which I follow it here as well. And local steroids does increase the risk of infection. So it is an acceptable treatment, but I think newer modalities of treatment are so fascinating that the use of steroids should be decreased.
So, Firoz, so basically this inflammatory arthritis involve your joint in a two-way. One, it's create inflammation that leads to involvement of the synovium. Second thing, it's the advanced stage, this involve your cartilage and joint. So once cartilage and joints involved, particularly if it is wet wearing joint, knee or hip, your steroid is not going to help for very long time. If it is involvement of only synovial capsule and the soft tissue, then definitely steroid is one of the treatment of choice. For the shoulder, again, this knee and hip is little bit doubtful in the sense of in the future this create more problem rather than giving delay.
Okay, thank you very much.
Thank you.
Now,
Sir, one question from either three of you. Lots of patients who are coming to your place for joint replacement, they are either taking some DMRDs or biologicals. So what will be your guidelines, whether to stop it or will you like to continue it, then you will do the operation?
So you are asking about the time of surgery?
Yeah.
So
timing.
usually I don't ask for a stop this DMRs.
So sir, the latest recommendation is that methotrexate can be continued. It doesn't increase your risk of any added infection. Whereas if they are on biologicals, anti-tumor necrosis factor and those kind of stuff,
14
then
days.
for biologicals 2 weeks pre-op and 2 weeks post-op till the wound has healed.
For all conventional, you have not to stop perioperative. You can continue all conventional DMRD. Except biological, you have to stop for 2 weeks. Another in between are those can be stopped for 1 week, and then after 1 week you can regarding the wound infection. Very nice talk. Thank you all, and we can allow another session. End of the session.
Thank you all the chairpersons for our guest faculties. I must introduce, he is Professor Anup Kumar, Head of Department of Orthopedics of All India Institute of Medical Sciences, Patna. Next is my younger brother Dr. Firoz Alam. He has come all the way. He is practicing at Gopalganj. My senior guardian, Dr. S.P. Gupta sir, and Colonel Santosh. He left army, settled in Patna. Now he is heading there in Medanta Hospital, Patna. Next moderator.
May I request Dr. Vipul for moderate the session?
Good evening, ladies and gentlemen. Good evening, ladies and gentlemen. I'm here to moderate the session 2. I must congratulate Dr. Amulya sir, who has given me the chance and for this great initiatives. Thank you, sir. May I call chairpersons Dr. Ajay Kumar Manav sir, Dr. Kamrul Hoda sir, Dr. S.K. Jha sir, Dr. Khurshid Alam sir. Please come and take the chair, sir. And today's evening, in the second session, the first chair speaker will be Kavita ma'am. Please come, ma'am.
A very good evening to all of you. Thank you, Dr. Amulya, for the kind invite. Happy to be a part of Aarcon 2024. So action against rheumatism, spondyloarthropathies is one of the leads in the list because the delay in diagnosis is, though with multiple referral strategies and with advancement of anti-TNF, diagnosis is happening early, but still there is a delay in diagnosis. I come from Pune, which is, I'm the professor and head of the Department of Clinical Immunology and Rheumatology at Bharati Vidyapeeth Medical College. So spondyloarthropathy is a spectrum. It's not just one disease. Earlier we used to equate it with just ankylosing spondylitis, but besides axial SPA, we also have a non-radiographic axial SPA where the X-ray may not show enough features, but MRI can pick up, the clinical features are there. We also have peripheral spondyloarthropathy within the spectrum, which can include psoriatic, reactive, IBD-related arthritis, and sometimes it still remains undifferentiated. So let us see this case, 35-year-old male with low back pain since 15 years, morning stiffness, classical Schober's positive, occiput to wall test positive. So this happens when there's delay in diagnosis and they come with a bamboo spine. As against this, as I said, the delay in diagnosis is getting lesser. This case was seen by us, a 41-year-old man, inflammatory low back pain and early morning stiffness for 3 years, but X-ray was already showing bilateral sacroiliitis grade 4. This patient is a 40-year-old male with stiffness for 45 years and bilateral sacroiliitis, but as you can see, the bamboo spine has already set in, so probably the pain and stiffness was more than 5 years. And this patient presented to us a few months back in March 2024, 32-year-old male with low back pain since 8 months. And this patient was seen in some other hospital where the X-ray was not very convincing of any sacroiliitis. MRI was done only for the lumbosacral spine. That happens quite often when the patient has backache. If we do not evaluate accurately, we just go for a MRI of the lumbosacral spine and the sacroiliac joint gets left behind. So he was advised NSAIDs and physiotherapy. In July 2024, when his backache worsened, he came to the rheumatology department. Here, as you can see, the X-rays and the MRI, both are showing signs of sacroiliitis. There's bone marrow edema, and the HLA-B27 PCR was positive. So at present, he's responded to NSAIDs and physiotherapy, but he's been counseled about the need of JAK inhibitors or biologics in the near future. So early diagnosis of SPA or spondyloarthropathy involves a good history, clinical examination, a combination of laboratory and good imaging. The checklist is whether the backache is inflammatory or non-inflammatory. Buttock pain is a very important symptom which is often missed out. Unilateral or alternating buttock pain is often an early clue. Existence of peripheral joint involvement is important. We often forget, or patient forgets to tell us, skin, eyes, bowel and bladder involvement, because ulcerative colitis, psoriasis, uveitis indirectly tell you there could be an underlying spondyloarthropathy. Family history or spondyloarthropathy, HLA-B27, psoriasis, all are very, very important. Young males, of course, one should suspect, But nowadays, the incidence of prevalence of spondyloarthropathy in females is on the rise. So there should be a high index of suspicion there too. And if labs are already done outside, they're always useful. So the first time we see a patient or SPA, we have to take the whole picture into consideration. A detailed history and study of the entire big file that becomes important. Almost all patients with axial spondyloarthropathy have a low back pain. An inflammatory back pain, by definition, is at least 4 of age less than 40 years. Gradual onset, improves with exercise but not with rest. Pain at night, and the patient wakes up because of the pain, especially to the second half of the night. And morning stiffness more than 30 minutes and alternating buttock pain. So the confusion arises because low back pain is very common. Many patients still have a mechanical back pain. And even if you define there is an inflammatory back pain, out of that also only 0.9 to 1.4% will actually have axial SPA. So we need to do imaging, we need to do more testing and constant follow-up. Neck pain is often also another symptom. Besides buttock pain, which we talked about, many of them have hip pain. Hip pain is also part of axial spondyloarthropathy in 25% of the patients, and also in 10% who do not have radiographic features. And this actually indicates a higher degree of disability or worse prognosis. They often don't complain of hip pain, they complain of groin pain, which would refer to the medial thigh and sometimes to the knee also. And if it's very severe, they often require early hip replacement surgery. Like this patient was a 38-year-old male, had low back pain according to him only for 1 year, but had a hip pain, and then we investigated, found grade 3 sacroiliitis, and he's now got better with intra-articular injection of a steroid into the hip, and we have also put him on tofacitinib. Also, the other thing is that there could be non-articular features, as I said, uveitis, psoriasis, etc. One needs to remember the HLA-B27 should be done by the PCR method, because flow cytometry, often done in many labs, is not adequate and you may need to repeat it. So though expensive, insist on a PCR method right from the beginning. Let's come to some criteria, assess criteria. So there could be imaging criteria and the clinical criteria. So if the patient has sacroiliitis on imaging, so one SPA feature is more than enough, or you can have more. In the clinical features, we have to have HLA-B27 plus 2 or more other SPA features. And the SPA features, as I said, inflammatory back pain, arthritis, enthesitis, uveitis, dactylitis, etc. The question comes in what is non-radiographic or SPA. That is one thing that is mentioned in many conferences. So whenever you have an active acute inflammation in MRI, it is sacroiliitis, but many of the patients do not have these features on X-rays. So if you have a grade 1 bilateral or a grade 2 unilateral sacroiliitis, then again it becomes a non-radiographic SPA. So in short, radiographic versus non-radiographic SPA are actually a spectrum of the same disease. Initially, they may not have features on X-ray. They may only have on MRI, and later on, as the years go by, if the disease evolves, they develop a full-fledged radiographic SPA. So the ones who go to radiographic SPA are males, positive HLA-B27, MRI, which is showing a sacroiliitis, high CRP, and in smokers. This diagram shows clearly that in spite of all these definitions, it is a continuum. And there's a very small category who will be HLA-B27 positive, high CRP. They may not progress also, and MRI also may not show, but they have all the clinical symptoms. So clinical correlation with all the imaging and lab investigations is important. So let's come to the topic of early axial SPA. Unlike rheumatoid arthritis, this definition is not very clear with axial SPA, but as per the ASA's definition, cutoff is 2 years. If the symptoms are less than 2 years, then it could be diagnosed as early SPA. Why it is important? Early reference, early treatment is going to help them. So imaging is very important in diagnosis of SPA. And we talk about conventional radiography, easily available and cheap. MRI of the sacroiliac joints is the ideal investigation to do for bone marrow edema. CT scan is useful for erosions. But when you do an MRI, you should insist on a semi-coronal T2 weighted, fat suppressed, or a STIR image. As you can see in these diagrams, STIR images which are fat suppressed are useful. Besides this, you should look for enthesitis, dactylitis, psoriasis, like this patient has got extensive psoriasis, and they have asymmetrical sacroiliitis, incomplete syndesmophytes, etc. Uveitis is like an emergency. If they have uveitis, we should be more aggressive with treatment. Another thing is females are coming with higher and higher prevalence of sacroiliitis, spondyloarthropathy. So we should not think if it's a female, it could be fibromyalgia or just postpartum, etc. So to sum up, axial spondyloarthropathy can exist with or without peripheral spondyloarthropathy. We should evaluate whether the backache is inflammatory or non-inflammatory. What is the age at onset? Is there family history? Is HLA-B27 positive? The symptoms, as we discussed. Also, we have to rule out the sacroiliitis due to infection like tuberculosis, brucellosis, and differential diagnosis like osteitis condensans, ILI, DISH, degenerative sacroiliitis, etc. Now, early diagnosis and early treatment, does it help? So statistics has shown that, literature shows that in the first 2 years, if the patient responds to NSAIDs, first NSAID, second NSAID, we can wait. But if the patient is not responding to second NSAID also, we should hit them hard with anti-TNFs, because the later you start the anti-TNFs, the lesser likely that the patient is going to respond. Thank you so much. That's my department and a hospital at Pune. Thank you.
Thank you, Doctor. Now I would like to call upon Dr. Raj Kiran Rudam to speak upon DMARDs, caution while prescribing.
Good evening, ladies and gentlemen. At the outset, I would like to thank my friend Dr. Aishwarya and Dr. Manish for inviting me here to give a talk on DMARDs, caution while prescribing. So DMARDs are, we broadly classify them into synthetic DMARDs and biologic DMARDs. I will try to simplify this talk to make you understand the key points of my talk. Among synthetic DMARDs, we have conventional synthetic DMARDs and targeted synthetic DMARDs. Conventional synthetic DMARDs are the drugs which we use routinely, like methotrexate, sulfasalazine, leflunomide, hydroxychloroquine. And the targeted synthetic DMARDs are the newer versions which we are coming across from last 2 to 3 years, tofacitinib and baricitinib. However, baricitinib generics are not available, and the original molecule is also not commonly available nowadays. And apart from that, we have biologic DMARDs like anti-TNF, anti-AL6, anti-AL17 and B-cell depleting agents. For most of our patients suffering with rheumatoid arthritis, we begin with methotrexate, which is a conventional synthetic DMARD. One thing which we should know here is, so when we start methotrexate, don't expect results immediately. Methotrexate and other conventional synthetic DMARDs are slow-acting drugs, and these drugs starts showing its efficacy only after 4 weeks. So when you start methotrexate, don't jump into conclusion immediately. After 2 weeks, patients comes back to you and says, I still have pain, and don't think that methotrexate is not working. So expect results of methotrexate only after 4 weeks or 6 weeks. So as I said, conventional synthetic DMARDs are the mainstay of therapy. And once the diagnosis of RA or spondyloarthritis is established, you need to start these drugs to prevent the radiographic damage of the joints. And the choice of drug depends upon a dialogue between treating physician or an orthopedician and the patient. And methotrexate is the most preferred drug and most widely used drug to treat inflammatory arthritis. But however, these drugs are used for very long term, as most of these diseases which we treat are all chronic diseases, and long-term therapies always come with lots of toxicities. So the key to reduce the toxicity is proper monitoring. So the most frequently prescribed drug among rheumatologists is methotrexate. As I said, the clinical benefits are seen after 6 weeks or 8 weeks of therapy. And various studies have shown that this drug can reduce the radiographic damage. And methotrexate can be combined with other DMARDs. Like we combine methotrexate with other conventional synthetic DMARDs like sulfasalazine, leflunomide, hydroxychloroquine, etc. And we also combine methotrexate with biologic DMARDs and targeted synthetic DMARDs. The beauty and flexibility of this drug is it can be combined with any other drug. And always the beginning dose is 10 to 15 milligrams, and we gradually escalate after 4 weeks. Every 2.5, then after 4 weeks we increase it slowly from 12.5 to 15 to 20. We can go up to 25 milligrams. So while adjusting the dose of methotrexate, we need to look at the efficacy and as well as the toxicity of this drug. So what is required when we begin methotrexate? So for all patients, whenever you are planning to start methotrexate, do complete blood counts and LFT, RFT and urine examination at the baseline. Don't start methotrexate if the patient's hemoglobin is very low or if the patient is suffering with thrombocytopenia or especially leukopenia, because these things may worsen in future if the patient is continued on methotrexate, or it might be some other disease going on inside apart from inflammatory arthritis alone. So then once we do these investigations, repeat these investigations based upon the clinical condition of patient after 2 weeks or after a month, then later on every month for initial 3 months when you are adjusting the dose of methotrexate. Then later on, once the patient gets stabilized, patient is in reasonable remission, then you follow up this patient once in 3 months and you can adjust the dose of the methotrexate accordingly and monitor the lab tests like CBC, RFT and LFT once in 3 months. Avoid this drug preferably if the patient is suffering with chronic liver disease, chronic kidney disease, and especially if they have viral infections like Hep B, C and retroviral disease. And the most important point is avoid this drug in preconception. If the woman is planning for pregnancy, don't give this drug. And always supplement with folic acid. And if 20 milligrams of, when you are in the process of escalating, when you are giving up to 20 milligrams and this drug is not working orally, it's better to switch to subcut methotrexate, because the bioavailability is better with subcutaneous methotrexate beyond 20 milligrams. And if the patient is unable to tolerate, it's always better and convenient to split the doses of methotrexate. And one thing you should always tell your patient when we give prescribed methotrexate is it has to be taken once in a week. Quite often it happens many a times, like whenever we prescribe methotrexate, we don't explain, our pharmacist also doesn't know. Like once in a while, patients land up with methotrexate toxicity. They keep taking methotrexate every day and they come with a very, very bad toxicity. It ranges from mild oral ulcers, mucositis, to some of the patients can have severe sepsis and they may die. So it's the most important thing whenever you are prescribing for the first time to your patient, ensure that, tell him that this has to be taken only once in a week. These are very, very simple things, but if you if you forget this, sometimes it may be very complicated. It may lead into very lot of complications. So other common side effects, patients might come to us with nausea, headache, diarrhea. This can be controlled by reducing the dose or converting oral into subcutaneous preparations. And when the patient is on methotrexate, patients might have like liver enzymes can get elevated. In those cases, just check what are the concomitant medications which is taking. When the methotrexate is combined with other drugs, like patient is continuously on NSAIDs or leflunomide or other combination therapies, the liver enzymes might go high. Don't just think that it is only methotrexate which is contributing for the liver enzymes. And in that scenario, also check for patient having any other liver diseases like alcoholic liver disease or non-alcoholic liver disease. All these things needs to be taken into consideration. Patients might complain of alopecia, treat them with biotin supplements, and most of the time, like once you give methotrexate, after a few months, patients start complaining of like immediately after the methotrexate day, they have severe malaise, fatigue, headache, dizziness. It can be controlled with split doses, and various things have been tried, like giving them, ranging from giving them coffee and like vitamin E. Lot of drugs have been tried to control these symptoms. But most of the symptoms may resolve in 1 and 2 days. And if the patient becomes extremely intolerant, you can stop this drug. Don't force the drug if the patient is intolerant on methotrexate continuously. So the toxicity ranges from cytopenia and methotrexate, lung disease or hypersensitivity pneumonia is a very, very rare problem. Most often we confuse, most of the doctors can get confused with the patient of rheumatoid arthritis on methotrexate if the X-rays or CT shows ILD, and it's often confused that it is the methotrexate which has caused ILD. Like, it's not. Methotrexate does not cause a chronic interstitial lung disease. Remember this, chronic ILD is part of rheumatoid arthritis. So methotrexate induced lung disease is always very acute, and it's it's an idiosyncratic reaction. Patient is extremely sick. In those conditions, you need to stop methotrexate and treat them with higher doses of steroids. And one thing which is forgotten, especially because rheumatologists also treat patients with methotrexate for very, very long time. And one thing which needs to be watched for if the patient is on methotrexate for more than 5 years or a decade is hepatic fibrosis. And that needs to be constantly checked in after a long-term methotrexate therapy, and always avoid the drugs like trimethoprim, sulfamethoxazole, like Bactrim DS with methotrexate, that it might increase the cumulative toxicity of this drug. One thing to be remembered is whenever we do a baseline LFT, look at albumin. And serum albumin, low serum albumin is a good marker. It tells us that it has been observed that patients who are having hypoalbuminemia are having higher risk of, they develop higher risk of side effects with methotrexate. And if the patient of like RA is on methotrexate and very bad arthritis, if the patient seems to have a mild ILD or a background ILD, still the current data tells you can continue on methotrexate. And one important thing for surgeons is methotrexate, if the patient of RA comes for THR or TKR and he or she is on methotrexate, you can continue methotrexate as per the current data. And follow-up liver scans if the patient is on methotrexate for more than 5 years. And hydroxychloroquine can be used in patients with low disease activity, and it's most often is an add-on therapy. And the dose, remember, whenever you're prescribing the hydroxychloroquine, don't cross the dose beyond 5 milligrams per kg body weight. So once you cross more than 6 and 7 milligrams per kg body weight, the toxicity can increase. It often causes skin pigmentation. If the benefits are more than risk, you can counsel the patient to continue hydroxychloroquine. It contains sulfate moiety. Sometimes it can cause rashes, pruritus, and nausea. Don't forget to do an eye checkup if you are giving hydroxychloroquine for a long term. So initially in first 1 year, you finish off a visual field test with slit lamp and fundoscopy, and then later on repeat once in 3 years, later on after 3 years or 5 years you repeat. And after 5 years, it's better to do an annual eye checkup for the patients who are on hydroxychloroquine. Sulfasalazine is used in mild to moderate disease activity, patients with mild to moderate disease activity. It's often combined with other DMARDs. And again here the important thing is whenever you start sulfasalazine, remember that the response is expected after 1.5 to 2 months. And it's a wonderful drug to give if the woman is planning for pregnancy. And again in males you have to look that this can cause azoospermia. If the male is on like having a risk of infertility and other issues, better to avoid this drug. It can cause very bad skin reactions like Steven-Johnson syndrome. It will have GI adverse effects. And most important thing one has to remember is always go low with sulfasalazine. Start with the lower doses like 500, and you can escalate up to 3 to 4 grams and gradually increase so that the toxicity risk can be minimized. Leflunomide, it's the data of the initial leflunomide tells that it's as good as methotrexate. You can combine with other DMARDs, and you can give 10 to 20 milligrams per day. And the most important thing is the combination of methotrexate and leflunomide has a higher risk of hepatotoxicity. So whenever you start methotrexate, whenever you start leflunomide along with methotrexate, it's better idea to start only with 10 milligrams and gradually over a period of time you can increase. The combination has other side effects like significant hair fall, so which has to be taken care of. Our patients needs to be counseled about these things, and more frequent tight monitoring is required. Monitoring every 4 to 6 weeks with CBC and LFT is required when we are using methotrexate and leflunomide combination or leflunomide alone. And avoid this drug in patients suffering with chronic liver disease, and avoid preconception most importantly. So there is a high risk of hepatotoxicity when you combine with methotrexate. This thing needs to be remembered. And quite often it's prescribed nowadays, and lots of pharma companies also come and promoting this drug, egorotamide. And unfortunately, it looks quite promising on paper, the pharmacokinetics and the mechanism of action of this drug. But however, the data is lacking on this drug. Our experience tells it's a reasonably good drug. in mild to moderate disease cases, and it's given ranging from 25 to 50 milligrams. The data in pregnancy and pre-pregnancy is not very clear, so better to avoid this drug if someone is planning for pregnancy. And one thing which is mentioned in most of the papers is avoid this drug if the patient is on concomitant anticoagulants like warfarin, and closely monitor if you are combining egarotamide with NSAIDs. And coming to the precautions and the cautions which needs to be executed when you are using drugs like biologics and targeted synthetic DMRs, I would recommend our audience to go through this paper which we have published in 2016, which gives you a list of the investigations which needs to be done when you are planning to start a biologic DMR or a targeted synthetic DMR. Routine investigations are a must, and the add-on to routine investigations, especially you are prescribing the biologic drugs or targeted synthetic drugs, is look for latent tuberculosis. So check chest X-ray we do even if you start on methotrexate, but do a Monto or a TB Gold to check whether the patient is having latent tuberculosis, because quite often it can happen if we start the biologics, anti-TNF drugs or tofacitinib for that matter for the patients, the latent tuberculosis can get flared up. And the targeted synthetic DMRs, the commonly used drugs are JAK inhibitors. As I said, baricitinib is completely now out of market. Tofacitinib is very well widely used. Tofacitinib we are using for various indications, like there are approved indications, there are off-label indications. After methotrexate, if you ask me any other DMR which is very widely used in rheumatology practice, it is tofacitinib. So that there are range of indications where we use tofacitinib, and it has been proven to be very, very effective, but it comes with package of a lot of side effects, and these side effects of tofacitinib can be higher if the patient is also on steroids along with tofacitinib, and the patient's baseline lymphocyte count is less. If the baseline lymphocyte count is less than 500, again it has been noticed that the risk of infections are quite high. And herpes zoster is again very, very common in patients on tofacitinib. And there is also risk of side effects in elderly, especially thromboembolic events, coronary artery disease risks are quite high, and malignancy risk has also been observed. So tofacitinib comes with lots of expectations. Generics are widely available, but the side effects are more than our placebo and methotrexate, and the side effects are almost equal to biologics. However, for us, it's not a first choice. So use wisely whenever you are prescribing tofacitinib. So the take-home message is, whenever you are prescribing a drug to the patient suffering with inflammatory arthritis, whether it is methotrexate alone or whether you are giving a combinations, first learn about the drugs, understand the drugs, know about the drugs whichever you are prescribing. And whenever you are using combinations, use a rational combination, because the combination, some of the prescriptions may have in patient tells like nothing is working. So in an anxious phase, we might combine almost all the drugs like methotrexate, leflunomide, sulfasalazine, egarotamide, but the drugs might cause more toxicity than benefit. So use rational combinations like methotrexate, sulfasalazine, or methotrexate, leflunomide. If they don't work, then you can always take an opinion of your colleague who is treating these drugs, and he can suggest to add another drug like a targeted synthetic drug or a biologic. And most important thing is, avoid these drugs if a woman is planning for pregnancy: methotrexate, leflunomide, tofacitinib, and egarotamide. And the most important key in treating patients suffering with chronic inflammatory arthritis is laboratory monitoring and early identification of infections, because these are the two things: the drug toxicity, the hepatotoxicity, and the infections. So these are very difficult, and these are very challenging to treat. Apart from disease-related morbidity, drug-related morbidity is also a key factor in bringing out the better outcomes in the patients. With this, I thank you, ladies and gentlemen. Sorry, I am a little bit overshoot at my time, and thank you once again.
Thank you very much. You have given very good insight for all of us for prescribing the medicine, or what are the pros and cons for giving all the medicine. Thank you very much.
Hello.
Now I request Dr. Kaushik Bhojani. Topic is All is Not RA.
Good evening, everyone. I have exactly 14 minutes, and so in 14 minutes, there's no point in wasting time on pleasantries. All of you know, whether orthopedic or rheumatologists or physicians, essentially rheumatoid arthritis. Rheumatology as a specialty has evolved over the years. Very recently, it's reached the pinnacle where people want to choose it as a super specialty. But we started with very basic, very basics. There weren't any drugs and there wasn't really a clear diagnosis. So this was the 1987 criteria, which all of y'all are familiar with. So severe morning stiffness, arthritis in multiple joints, small and large joints, it should be symmetric, there should be subcutaneous nodules and so on. And then as the science evolved, we reached a stage where we started classifying, we started scoring, we started quantifying the disease activity and choosing our drugs according to that. And that's when each of the classification criteria changed. Mind you, the classification criteria are not diagnostic criteria, but they do serve as a guideline for you to know where you stand and whether you're going to be able to treat the patient effectively or not. The orthopedic forum out here has all kinds of specialists. So you have your shoulder surgeons, people who have your spine surgeries and so on and so forth. But tell me, when a patient comes to you with 11 joints, what are you going to do? How many are you going to operate? And what kind of life are you going to give the patient if the knees are replaced beautifully, or if you've done your reverse shoulder replacement, but the patient's ankles are fused so the patient can't walk and the patient's wrists are fused? So regardless of the fact that you took away the pain, what is the quality of life? Now, importantly, when you treat, you also need to know what is not RA, right? So that's my basic stuff. So this was a 54-year-old lady who came with duration. I'm going to keep it purely clinical. I don't want didactic lectures, theory, and so on and so forth. Progressive finger deformities, there was pain, some days bad, some days okay, stiffness mild, rheumatoid factor positive, and what do you think this is? There are deformities and so on, but the interesting part was that this was primary osteoarthritis. This wasn't rheumatoid arthritis at all. The challenge comes, the bitch of it is when you get something like this. And when you get something like this, what are you going to do? Are you going to be able to treat this? But the important part here is, once again, this is not rheumatoid arthritis. This is a scleroderma. If you get your diagnosis clear, is when you're going to know what direction to go in, because otherwise you're going to miss the boat anyway. This is a 33-year-old female who had joint pain, swellings, had been to not only physicians, orthopedic surgeons, and in fact, multiple physicians. So this was way back 15 years ago, where, even our knowledge has really evolved in the last 15 years. So methotrexate, 2.5 milligram, 5 days a week, exactly opposite of what Raj Kiran was just telling you. So Monday to Friday, methotrexate was given 5 days a week, hydroxychloroquine, sulfasalazine, no improvement, leukopenia, patient had altered liver function, lot of rash, lot of oral ulcers. Everything that Raj told you was all there in this patient. Look at the hands. And if you notice a little closely, you will realize that there are skin lesions. And this was a dermatomyositis. This was really not a rheumatoid arthritis at all. Mind you, every rheumatic disease is going to come to you with hand joint pains and knee pains and ankle pains. That doesn't mean every pain in every finger and every toe is rheumatoid arthritis. This is very simple. So I'm not going to waste your time on it because I have exactly 10 minutes left. But this is primary erosive osteoarthritis, and the synovium is bulging out from the Bocard's and the Haberden's nodes. And for donkey's years, there was no treatment available for this condition at all, isn't it? And it might give you some pride to know that the first man who actually held the baton for trying to treat osteoarthritis as a rheumatic disease is from India. He's in Lucknow. He's now in his 70s. He actually started it, and even we rheumatologists used to wonder, kya isme sikhayenge? Every year he talks about this topic, but his passion continued. Now we are actually exploring biologics even for primary erosive osteoarthritis, because at the end of it, the pain is not bad, the progression is slower, but the disability is the same. This was a 34-year-old male, asymmetric arthritis. After gym workouts, developed low back pain, so he was badly disabled. One ankle, one knee, as you can see, quite swollen. There are some skin lesions, and he had this recurrent episodes of slip disc pain. But then, as Dr. Kavita was talking about, this gentleman, now mind you, don't think that spondyloarthropathy will not have finger joint pains. So if you have the enteropathic variant, if you have the psoriatic variant, if you have the reactive variant, you will get finger joint involvement, and unless you have your classification criteria. So if you want to know what is not RA, this is what my teacher used to teach me. Think laterally. First learn what is RA so that you know what is not RA. And master RA so well that the moment it deviates from the rules that you have imbibed in your brain, you're going to know, okay, let's look for something else. This was a young girl, severe pain, multiple joints painful, but this finger was disproportionately painful, and she was feeling a little weak and feverish. You can see the sausage kind of, the fusiform kind of a finger. Now, a rheumatoid arthritis will not have the shape of a fusiform finger. So the moment you get that, you know you need to look for something else. And this was tuberculous dactylitis. By the way, this patient had been started on methotrexate before I saw her. This is simple, so I won't waste your time on this. But when you look at this, and this gentleman comes to you, and there's this history of alcohol, and there's this history of toe deformities and relapsing remitting pain, yes, you're going to say this is acute cofacious gout. You're going to give the entire diet restrictions and all of that. But what happens when you get a chronic tophaceous gout like this, who looks like a rheumatoid, behaves like a rheumatoid, the deformities are as bad, and when you do x-rays, you realize that the joints are eroded. That's when you need to master the erosions on the x-ray of a rheumatoid arthritis versus a gout to look at the overhanging edges even, or the erosions that happen in a chronic tophaceous gout in the hand. And this was total gout, okay? And this gentleman, just for your information, was not an alcoholic, was a pure vegetarian. This was a genetic predisposition. This was a 16-year-old boy with progressive stiffness, deformities of the fingers and the other joints, and his rheumatoid factor had been done twice, which was negative. Early morning stiffness was about 20 minutes, and he had been having slightly stunted growth. The moment you get something like this, even I don't touch this patient, I send them off. This is a spondyloepiphyseal dysplasia. There's nothing really that even a rheumatologist is going to do out here. This gentleman had pain and stiffness in one hand, so the onset was asymmetric. All of us rheumatologists talk about the fact that you should have bilateral symmetric, small and large joints, blah, 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 whatever it is. But is it necessary? V.R. Joshi, my teacher, used to say, diseases do not read textbooks. So don't expect that a disease is going to behave like this, which means that if one joint comes in first and the other joint comes in later, that's possible, right? The disease has decided on its own what it wants to do. And hence, this gentleman came with first one hand swelling, fingers, hands, wrists, MCPs. The rheumatoid factor was positive, and later the left hand started paining. And the background history was he was a diabetic, and he had a left-sided cerebral tumor operated 2 years ago. Ring a bell? So this was like an RSDS. There was a left-sided cerebral tumor which was operated, and if you correlate, you will realize that a few weeks later is when the right hand got involved. Now add to that the fact that the patient was diabetic. So when you turned the hand around and you looked at it, there was overuse of the opposite hand now because the right hand had become like this, and the namaste sign was positive. And when you looked at the other side, there was flexor tenosynovitis because of the diabetic arthropathy. So this is completely misleading. This gentleman was treated with methotrexate, leflunomide, everything that Raj said. He just made my life easy. I didn't know I would have to speak after him. Just made my life easy to tell you, and it's just going to go on in my tomorrow's talk about what not to do in RA. But methotrexate 7.5, leflunomide given in combination, patient developed jaundice and leukopenia. Thereafter, patient was given methotrexate plus sulfasalazine together along with hydroxychloroquine, leukopenia, liver enzymes elevated, hence stopped. Then given methotrexate 5 milligram, leflunomide 10 milligram, no washout given. Every time this was changed periodically. And this is how this gentleman was. But if you had to just focus on the cuticles of the nails, you would realize that this is a little more than rheumatoid arthritis. And then once in a while when a patient comes to your joint pains, it helps to look at the toes. So this was a psoriatic arthritis. This was not a rheumatoid at all. And a psoriatic arthritis will come with its component of liver fibrosis, will come with its dysmetabolic, they have a metabolic syndrome as well. So they have a dyslipidemia, sometimes they are diabetic and so on. So this is to give you a flavor of what we rheumatologists do in the OPD. It's not treating joint pains, it's doing what not to do is more important than knowing what to do. Every textbook tells you what to do, but it's a teacher who tells you what not to do. So this was long-standing finger joint pains, no swelling, but the deformities had developed over time, and this patient came to us after some 10 years history. So that itself should tell you, if it is 10-year history and the patient is still active, then there's something else going on. So this was ligamentous laxity, because you could, this was Yakut's arthropathy, and the patient then volunteered that there was a history of Ayurvedic intake, there was fever and rash and joint pains for a long, long time. So possibly the indigenous Ayurvedic preparations contain steroids which kept her lupus going. So this was essentially a lupus who eventually, because got deformities despite treatment and had gone into remission, is why she came. And this one is where I am going to thereafter close. This gentleman actually gate crashed my OPD. Lying to my receptionist that I am his old follow-up patient from his earlier hospital and I'm very disabled, and my receptionist in all good faith so I took him in. And after blasting him, I realized I don't blame him for what happened. Bilateral carpal tunnel syndrome operated by an orthopedic surgeon. Bilateral, mind you, a bilateral carpal tunnel syndrome does not happen. If it happens, you've missed it. There's something wrong. And so ankles, shoulders, joints involved, pain was continuous, there was anorexia, there was weight loss, there was feverish feeling, there was no relief from DMARDs. And if you can see, yes, surely he has synovitis and he has deformities, and in fact he has subcutaneous nodules. But if you had to focus on his elbow, on his forearm, you will realize that it's not one subcutaneous nodule, there's a line, it's irregular. You don't have a classical subcutaneous nodule, you have multiple small nodules which are streaming down the forearm bone. And I know orthopedic surgeons don't look into the mouth of people, but we physicians have to. So that's why all of us died because of COVID. Most of us did. But this is what the finding was. He had a little hoarseness of voice while giving his history, and he had a very large tongue with the teeth marks on his tongue. And that was the giveaway that this is polyarthritis but not rheumatoid arthritis. And this gentleman was primary systemic amyloidosis. He's still alive, comes to me, meets me in Diwali every year. He's 10 years older than me, but still comes to take my blessings. It's quite embarrassing because he does it in public, but he's still alive. This is what you don't want to miss. You want to look behind the ears, you want to look at the nails, and the nails will tell you that this is not rheumatoid arthritis, because this could just be nail pitting of psoriatic arthritis. You don't want to miss this. And this is what you would also want to look at. This woman comes to you with joint pains and weight loss, and if you admire her face, you will realize it has a faint rash. And if you open the mouth, you'll realize there are palatal ulcers, and if you look at the hands, you'll realize there's vasculopathy. And that's lupus. Thank you very much.
Dr. Ishan Mishra.
No, no. Question answer.
Question.
This session is closed. Now we are going to question answers.
Any question from the audience, from the respected teachers? They have orated very well, and I thank you for enlightening
Hello.
us.
My question is from Dr. Kaushik, sir. Yes. Sir, in my practice, I have one patient having the bilateral carpal tunnel. I have diagnosed doing the NCB and EMG study, and NCB shows that there is the severe compression at the both wrist joint, and I have given 2 bot of the intra-tunnel corticosteroids, dipomedrol, in the gap of 15 days, and patient relieved almost 90%, and I have given injection about 6 months ago. Now patient is coming to follow up. Now he is all right. Bilateral carpal tunnel.
Male.
Female.
See, this is where the beauty of medicine comes in. Okay? I have very close orthopedic surgeon friends who tell me I think like a surgeon, I talk like a surgeon, I write my pre-operative protocols like a surgeon. So I have instructions for the anesthesiologist, what X-ray I want, what eye drops to be put, whatever, before I send my patient for a knee replacement. But still I chose general medicine. And this is the beauty of medicine. So first, this was a male. You don't compare the two. A male bilateral carpal tunnel cannot happen, number one. Number two, a female bilateral carpal tunnel can even happen in pregnancy. You need to relieve it. You're an orthopedic surgeon. Of course you need to relieve it. So whatever you did is really not in question. Point being, if they happen simultaneously, look for an underlying systemic disease. So can a rheumatoid arthritis do a bilateral carpal tunnel? Of course it can. If you have bilateral wrist synovitis, it will do it. But is it really a hypothyroidism, and have you treated that? That's the bottom line. But you have a male bilateral carpal tunnel syndrome, your alarm bell should go up.
Thank you very much, sir.
Dr. Rajkiran, you mentioned about this methotrexate and other drugs, but frankly speaking, you must be also seeing the way pharmaceutical companies have promoted tofacitinib. Everybody, I'm not talking about you. We orthopedicians are writing much more without realizing, and you have cautioned us again. So again, some take-home message, especially for the orthopedicians, when to start tofacitinib. Generally, people are starting right from the first day without adding methotrexate and everything. We are starting it. What precautions we have to take? What we are doing is wrong. You have to again teach us, sir.
Thank you, Amulya. Tofacitinib is not the first-line drug of choice for rheumatoid arthritis. So whenever we diagnose rheumatoid arthritis, the first drug of choice is methotrexate, unless it is contraindicated there or the patient is intolerant to methotrexate. If methotrexate doesn't work, you can add some other drugs to the methotrexate. In that phase, this tofacitinib comes. Don't straight away start with tofacitinib, because in my last slide I have mentioned the side effects, because whenever we treat any patients, we need 2 things. One is we need to have the efficacy, and we should not have the toxicity. In that lines, if you see, the toxicity of tofacitinib or the side effects or the serious adverse events of tofacitinib are much higher compared to the conventional synthetic drugs like methotrexate, sulfasalazine and leflunomide. So that is the reason tofacitinib is, at least till now in the guidelines, it's not mentioned as the choice, the first choice to begin with. But however, having said that, there are some exceptions for everything. Like if you have a very aggressive disease, like where you can't give steroids to the patient, because most often, as I said in my talk, we need to remember the drugs like methotrexate, sulfasalazine or leflunomide, the conventional synthetic DMRs takes a lot of time to act. So we combine giving them with steroids or NSAIDs or other drugs to control the disease. So we have a very aggressive disease where we can't use these steroids or NSAIDs, you can still combine. with methotrexate. But however, the bottom line is, don't start tofacitinib to all your patients whom you have diagnosed rheumatoid arthritis at first.
Sir, excuse me. Sir. Is there any advantage of using methotrexate twice a week or over the once a week dose? We divide the dose into.
No, as such, there is no advantage of giving twice a week. In fact, actually, when you give twice a week, the risk of toxicity may increase further.
No.
So
Using the dose the same.
Yeah.
15. If you want
No,
to
I got your point.
Yes.
Instead of giving once in a week like Sunday, if you can give Sunday and Wednesday, does we have benefit like that? No. So as I said, the benefit and risk, if you see, so the benefit might be there, but the risks are more when you are exposing more methotrexate there, because methotrexate, what happens is when you give methotrexate to the patient, it will disappear from the blood within 1 or 2 days, and it will go into RBCs and get settled there. So there will be more of toxicity. So that's the reason we don't give like more than once in a week. So the risk of toxicity, fearing the risk of toxicity.
Raj, I would like to know what is the vaccination protocol you would like to follow, and will it be different when we are using targeted synthetic drugs?
So tofacitinib, the risk of herpes zoster is quite high with tofacitinib, because we have noticed significant risk of like zoster in patients, especially when we combine tofacitinib with other drugs rather than tofacitinib monotherapy. The patients on tofacitinib with steroids and methotrexate, the risk of zoster is quite high. So when we are intending to use tofacitinib, yes, zoster vaccine, it's better to be given before initiating tofacitinib. But however, if the patient is already on tofacitinib also, still we can give zoster vaccine. Zoster vaccine is one thing, and the other thing is the perennial flu vaccines and pneumococcal vaccines needs to be given, especially to our patients like who are elderly and who are at risk of developing these infections.
Dr. Kavita, just you have a question? Just one question. We orthopedicians are having lots of patients with heel pain or swelling on the posterior aspect of the ankle joint.
Right.
We diagnose it, if there is a heel pain, we diagnose that as a calcaneus plantar fasciitis or calcaneus spur.
Yeah.
How do you find it, where we can call it going towards a spondyloarthropathy?
Yeah, so actually that I'm really covering more in tomorrow's talk on ankle and foot, but I can just say in brief. So whenever there's enthesitis, so it is at the posterior part of the heel, and sometimes we are not sure. So if it's just at the heel, the swelling posterior part, usually it is enthesitis, and plantar fasciitis is more towards the sole, more on the medial aspect. In these cases, often an ultrasound helps, because we've had 1 or 2 patients, even if they had a double contour sign, it was gout also. So heel pain sometimes can be challenging. X-ray, if it shows a spur, and then if you have classical tendon on the medial side, then I think plantar fasciitis is more likely. If it is more posterior and ultrasound shows synovitis or a DC sign, then enthesitis or gout is. So MSK ultrasound is quite useful in these patients. Yeah.
You want to ask?
So I have just 2 doubts. One thing, sir, about the herpes zoster. If someone is having history of herpes zoster, still we can give the vaccine. And another one, sir, we used to give to start with usually one more drug with methotrexate. So among sulfasalazine and HCQ, which one you prefer, sir, if we need to add?
With methotrexate?
Yeah.
No, it depends upon the severity of disease. Suppose the patient is having high disease activity and methotrexate alone is not working, because hydroxychloroquine is not as effective. If you choose the efficacy of, if you look at the efficacy of sulfasalazine and hydroxychloroquine, sulfasalazine is slightly more efficacious than hydroxychloroquine. So whenever if methotrexate doesn't work, if it is only just little bit of activity you need to control, you can add hydroxychloroquine, but there is lots of activity. In fact, actually we combine, there is a triple drug regimen, like we combine methotrexate, sulfasalazine and hydroxychloroquine also to these patients. And coming to your earlier question, if the patient has already had zoster, so then no need to give vaccine.
Sir, can you, Dr. Raj?
I'd just like to add a little bit there. If the patient has had zoster, the patient is completely immunized for about a year. But you're going to use about 1 year, completely immunized. But you're going to use immunosuppressants, so your situation is different. You're modifying the patient's immune system yourself. And the virus remains in the immune system to the myelin sheath for years together, so the patient will get a relapse. Patient may not get a relapse till the antibody titers are very high in the first 1 year, but 1 year of immunosuppressants, the patient will get a zoster. That's when you vaccinate. Having said that, if you do not follow the guidelines of holding the immunosuppressants during the vaccination process, 2 weeks in the case of methotrexate and 3 weeks in the case of tofacitinib, your immune response will not be so good. So you also need to understand that. This is the beauty of looking at the person as a whole. Is the patient a diabetic? Is the patient on immunosuppressant? Is the patient on other disease modifying drugs which are not immunosuppressant? So for example, hydroxychloroquine and so on. If the patient is a hypertensive, what is the renal excretion? What is the liver status? And that's when you decide your DMARDs, or that's when you decide your vaccination protocol. There are no fixed rules, there are guidelines. The guidelines will only tell you, recommended do this. The rest of it is your clinical judgment, because no two patients are the same.
Regarding, I just wanted to add, you asked about methotrexate, excuse me, the twice a day, 2 days a week methotrexate and 1 day a week. This one thing, if the dose is more than 15 milligrams, if you're giving 20 milligram or 25 milligram weekly, then it's better to divide it in 2 doses in a week, in a day, or 2 days you can take. To 15 milligram once a week is fine, like Sunday or Saturday. But if you're giving 20 milligrams or 25 milligrams, then you should give 2 divided doses. So either you can give 15 milligrams and 5 milligrams in the evening, or then Saturday, Sunday.
Can we decide the dosage on the weight of the person? The fixed dose is for everyone, 15 milligram, 20 milligrams. We generally use 15.
Yeah, 15 milligrams is.
Depends on the height, weight.
In children we give up to 0.3 milligrams per kg, but not in adults. We generally start with 10, 15, 20, up to 25.
Well, Kaushik, I would like to know more about the patient who had tongue sore in the tongue. So, would you elaborate on that particular patient? You said it is amyloidosis.
Oh, you're talking about the 50-year-old male.
Right.
Yeah. So this gentleman had he started with polyarticular joint pains, gradually progressive. He had synovitis clinically, but he had a lot of systemic symptoms. And so he seemed to have anorexia, which was progressive, loss of taste in mouth. Over a period of time, he developed his voice timbre went down, speed became slow. Now you must understand one thing, that when you are dealing with a polyarthritis, the patient's speed becoming slow because of pain is different from the patient saying that I don't know why I have become slow. Why should rheumatoid arthritis in the first 2 years affect the vocal cords? Rheumatoid arthritis affecting the vocal cords is, long standing. It can. Please understand one thing, if I can put in this message in front of you, that what the beauty of rheumatology and rheumatic diseases, and let me give you an example. One of the world's authorities in spondyloarthropathy is an orthopedic surgeon. His name is Xenophon Balakios. He's one of the world authorities. He's just given up orthopedics completely because he was just so enamored by rheumatology. He's considered to be one of the world's authorities in spondyloarthropathy at this point in time. This is the beauty of medicine. The beauty of looking at the systemic features together. You look at just the synovitis, you look at just the joint pains, you need to look at whether this is arthritis versus an arthritis plus syndrome. And if you have anything which is beyond your map of just a plain garden variety rheumatoid arthritis, think again. think twice, think 3 times, because the moment you start the patient on some treatment and modify the clinical picture of the disease, after that, the progress is going to change, the picture is going to change, and it gets very difficult thereafter to know where it started and the patient just progressively deteriorated. So this is what happened with this guy. He developed thereafter very large ischial tuberosity lesions because of which he couldn't sit. And he had vocal hoarseness. This can't happen in rheumatoid.
Right, thank you. One thing, as far as spondyloarthritis treatment is concerned, use of sulfasalazine is practically being done in all parts of the world, especially in Asian countries. Though we know it does not work on spine and it will work only on peripheral joints. Would you like to re-emphasize its role in axial spondyloarthropathy?
Yeah, so
And the maximum advocated dose you say is up to 4 gram. So where would you like to limit your dose?
Yeah, definitely sulfasalazine has a role in peripheral spondyloarthropathy. It's also good in enteropathic, where there is Crohn's disease or especially ulcerative colitis. But I usually don't go beyond 3 grams because it invariably causes some toxicity. One has to remember that with the new drug that are available, young males are affected who are going to get married or already married, planning a family. So in fact, educated patients do ask you, is my sperm count going to go down? So when the disease activity is very high, so axial spondyloarthropathy, you should offer anti-TNFs or even JAK inhibitors early to them. In fact, giving sulfasalazine in axial spondyloarthropathy is just buying time. Maybe even NSAIDs are only working. So if it's peripheral SPA, definitely we should offer sulfasalazine. Again, I feel if the axial component plus peripheral component offered anti-TNFs only to them, because that works fast, it brings about disease activity control very fast. And axial SPA is a waxing and waning entity. They do go into remission early. So I think for peripheral, it's fine.
I think most of the guidelines currently, they don't consider sulfasalazine in isolated axial SPA. So isolated axial SPA, sulfasalazine is not the drug. It's NSAIDs, and if NSAIDs physiotherapy doesn't work, then anti-TNF or tofacitinib, as madam said rightly, because most of these patients with axial SPA, they have alternate buttock pain, one side, left side, then later on right side. Or they will be into decent remission, but some of them they progress, some of them they don't, and if they progress, they slowly go into ankylosing phase. That is a time we need to pick them up much earlier. If they are worsening and if the pain is not improving with NSAIDs continuously, that is a time patients needs to be like offered anti-TNF drugs or the JAK inhibitors. And coming to up to, usually it's described like we can go up to 4 grams. Yes, there are some patients whom we give up to 4 grams, but most often there are a lot of GI intolerance once we give beyond 2 grams. So they don't tolerate much, but if people tolerate, we can go up to 4 grams, and it also works, especially in patients with where we can't give other drugs, like women preconception, we can't give methotrexate, tofacitinib, and sometimes anti-TNF may not be that effective, though these drugs work. So as Kaushik said, there is a special place, and in internal medicine, like each patient though comes with same disease, it's entirely different. So based upon his drug tolerance and based upon his other comorbidities, and so each patient is different. So we need to take decisions based upon the case to case.
Thank you very much to all speakers for the vibrant discussion.
Yeah, thank you, chairpersons. Now for the third session, may I have the moderator on the chair? Thank you, all the chairpersons. So actually, I did my graduation from Armed Forces Medical College. So I'm very strict on my timings. We started right what you saw at 6:30, but there were naturally some delegates who were here. Can we have a lucky draw? One lucky draw. Even your name can be there, but we will not give it to you. And that is registration number 37. 37 registration number, who is there? Alok? Oh, sir, yahan Dr. Professor Aarcon will present this bag to him. Early incentive In spite of the bad weather, you were here. Next moderator, please be on the dais, please. Next moderator. आप अपना शुरू करो। ये आलोक को देना है सर यहाँ।
Good evening. Our third session, I'd like to invite for chairpersons Dr. Brajesh Kumar Singh, please sir, on dash. Dr. Mithilesh Kumar sir, please on dash. Dr. Raj Kumar, please, and Dr. Ikram, please on dash. Our may I request Dr. Rajiv Ranjan sir for his presentation.
So, good evening everyone. I am Dr. Rajiv Ranjan and I will talk about management of ankylosing spondylitis. So, this is very important topic. Why it is important? We all know that this ankylosing spondylitis affects the young population. And if we can't treat this patient on time, they develop multiple deformities, spinal deformities and long-term poor prognosis. So the important goal is that to treat early. So if you control the inflammation very early, you can prevent the deformities and disability. So important goal is obviously you have to treat to target, and the early treatment is always rewarding. So there are 4 important pillars for the treatment. One is to control the inflammation, so we can control the symptoms of the patient. The second is to prevent the structural damage by controlling the inflammation, obviously. And the third is, if you can control the inflammation, you can prevent the deformities, and you can also normalize the function of the patient and social participation. And the last and not the least is to prevent the complications related to the disease, related to the drugs. So the principal primary care management should be done by a rheumatologist. You have to measure the disease activity. Every time when the patient comes to you, you have to measure the symptoms, how much the symptoms are related to the inflammation, how much the symptoms are related to some other cause. You have to also objectively measure the sign of inflammation. Then you have to measure the inflammation severity by some investigation. So disease activity measurement is very important, and you have to adjust the treatment accordingly. So obviously there are 2 types of treatment, non-pharmacological and pharmacological. So many of the patients comes with multiple non-specific pain or fibromyalgia kind of symptoms, because these patients, if not treated on time, they develop multiple severe deformities and they develop multiple psychosocial symptoms also. So we need to address those symptoms also. So all patients are different. Even if you see the 10 patients of ankylosing spondylitis, each patient is different by the severity of the disease is variable in each of them. The pattern of involvement is different. Some patients have very predominant peripheral involvement. Some are having very axial symptoms. Many comes only with the acute anterior uveitis. So the pattern and severity is very different. And the response to treatment is also very important. Some patients get improvement by the NSAID only. Some do not develop any improvement with the NSAIDs at all. So it means the patients are different. So you have to personalize the therapy accordingly. Non-pharmacological treatment is very important, and most of us, we don't give these non-pharmacological treatment to the patient. The first and most important is correct education to the patient. What is the disease? How it behaves in the future? What are the treatment options? Is there any cure or not? So these are the things, these are very common things that we don't tell to the patients, and this lead to the treatment defaults. Exercises are very important. Here comes the role of physiotherapist. So most important thing is say no to tobacco. Smoking or any form of tobacco will lead to the aggravation of disease or flare of symptoms. So no to tobacco is very important message that you have to tell to the patients. Depression and psychosocial support is very, very important because many of patients search in the Google, they see that I am HLA-B27 positive, I will develop so much deformities in the future, and they start thinking a lot. So psychosocial support and depression is very common in almost all the rheumatic disease, and especially in the ankylosing, where the patients are a young adult and they think a lot about their futures. So what we have in the hand, we have 3 different modalities of treatment. First is obviously non-steroidal anti-inflammatory drugs. Second is synthetic DMARDs, and the third is biological molecules. So coming to the non-steroidal anti-inflammatory drugs, NSAIDs, so dose should be given up to maximum tolerated dose. Which NSAIDs are superior? There is no one molecule, no one NSAID is superior to the another. Both COX-2 and the traditional one are almost similar efficacious. There is pharmacogenetic thing in the NSAIDs. Some patient responds very well to one particular NSAID. Some may not respond at all to that particular NSAID. So here comes the role of pharmacogenetics. So you have to give at least for 2 to 4 weeks. This is the first line of treatment. If there is no response in the first 2 weeks, you can change to another NSAID. Continuous, but there is always a debate between the continuous NSAID use versus on-demand basis. So when the disease is active, you can use continuous basis. When the disease is not so much active or mild, you can use as a on-demand basis. There are also multiple factors are taken before deciding I have to give this NSAID as a continuous or on-demand basis. So remember all the side effects of NSAIDs and the contraindication, because if someone is having peptic ulcer disease, you can't give. Someone is having cardiac problem, kidney issues, you can't give. So always remember all the important contraindications of NSAIDs. So diclofenac and COX-2, they have higher cardiovascular side effects. So you have to also keep in this mind when you are using this NSAID in elderly patients. So these are important some trials. So obviously we have high to moderate quality of evidence that it says that both traditional and COX-2 are efficacious. No one is superior. And the second, we have low quality to moderate quality of evidence that continuous NSAID use may reduce the radiographic progression, but it needs to be confirmed in multiple larger trials. So there is also one important thing that if you are using NSAID and there is no improvement in the sign of inflammation, you have to change and almost 40% of the patient and more than 40% of the patient do not respond to the NSAIDs. The second line important is conventional synthetic DMARDs. So coming to sulfasalazine, earlier we have very good discussion about sulfasalazine. So sulfasalazine, methotrexate and leflunomide, they are not recommended for axial manifestation of ankylosing spondylitis. But sulfasalazine may deserve consideration in a patient who are having peripheral joint. So you can use in peripheral arthritis, but when there is an axial symptom, predominant axial one, it has less effect on the axial symptom. So these are some trials where it has been shown that methotrexate has no role on the axial symptom of the ankylosing spondylitis. For sulfasalazine, there is some reduction in the early morning stiffness, some reduction in the ESR when used for axial symptoms. So it has some role, but not a great role. So the role of sulfasalazine in axial symptom is controversial. There is less evidence for the axial symptom. We have no such RCTs in the Western countries for sulfasalazine in the axial symptoms. It is working more and very good for peripheral arthritis. But when we look at practically, we see that some patients responds very well for the axial symptoms also. So who are those patients? So we have one trial from PGI Chandigarh, and this looks for RCT, sulfasalazine in axial disease of ankylosing spondylitis. So those patients who are younger, less than 25, having disease duration less than 4 years, and having high disease activity or high CRP, they responded, almost 60% of the responded well in axial symptom of ankylosing spondylitis. Now the another drug is iguratimod. This is very less used. What is this? This molecule, I can say it's not a true DMARD. It's a combination of, you can say, the NSAID and DMARDs. So it blocks the COX also, and it also blocks some cytokine also. So there are almost the recent systematic review and the meta-analysis, we have 84 RCT for the iguratimod, and the 9 RCT were focused on the ankylosing spondylitis, and it was found that this molecule also decreased the BASDAI score significantly, BAS5 score significantly, pain visual analog scale significantly, and also reduces the inflammation level. So it may work. So when to use biological DMARD or targeted synthetic DMARD in ankylosing spondylitis? So obviously there is a diagnosis of ankylosing spondylitis by a rheumatologist, and having high inflammatory markers in the form of CRP, there is a positive evidence that there is a inflammation, and the failure of the NSAID, at least 2 NSAID over 4 weeks, there is no response, or the patient is having high disease activity. For the peripheral arthritis, you can use the sulfasalazine, and one local steroid injection can be given for peripheral arthritis. And even after that, if the patient is having high disease activity, like ASDAS score is more than 2.1, BASDA is 4 or more than 4, then you can start the biological therapy. So most of the guideline, they give NSAID as a first-line therapy, non-pharmacological treatment given to all the patients. For peripheral arthritis, you can use the sulfasalazine and also methotrexate. Local steroid can be given for the peripheral arthritis or enthesitis. And the biological TNF blocker, IL-17, and targeted synthetic DMARD, tofacitinib, is used as a second-line therapy. So 2022 guideline, SS and Euler guideline, they have also recommended the same, use as a start NSAID, titrate to the maximum tolerated dose. If there is a less response at 2 to 4 weeks, not a sufficient response, then you have to evaluate the disease activity. If there is a high inflammation, then you can go for the second line therapy. So which one is better out of all the three, anti-TNF, IL-17 inhibitor, and targeted synthetic DMARD? So usually the guidelines are in the favor of anti-TNF as a current practice, or IL-17 or targeted synthetic DMARDs, they can be used. If there is a history of recurrent uveitis, if there is a history of inflammatory bowel disease, monoclonal anti-TNFs are used. If there is a significant psoriasis, obviously IL-17 inhibitors are used. So almost all the different world guidelines are in the same manner. So factors, there are multiple factors taken into consideration before giving a biological molecule. So first, how this particular molecule is efficacious or not, how much is the efficacy. Second is how much is the efficacy on the skin symptoms, especially the psoriasis. What are the safety profiles, in which group this biological molecule will have less side effects. Fourth is what is the extraarticular manifestation of that biological molecule, like in the uveitis, IBD is there or not, is there any psoriasis or not. So risk of TB reactivation is another thing that we keep in mind before giving the biologicals. Risk of serious hospitalization due to infection or opportunistic infection in last 1 year is taken into the mind before giving biological. Immunogenicity is another component that is taken into account, because these are the molecules, when you give a biological molecule, there is antibody formation. We call anti-drug antibody. There is also persistence or adherence to the therapy, convenience, and obviously the cost, bioinnovator versus biosimilarity. So I mean to say that there are multiple factors. Before giving any biological, we take all these factors into account, and then we give any biological to a patient. So the two important molecules is anti-TNF and IL-17 inhibitors. So regarding anti-TNFs, which anti-TNFs are better? All anti-TNFs are same efficacy. No one is superior. There is no one head-to-head trial. So the target is that we have to achieve either remission or low disease activity. If the patient is having more than 6 months of sustained remission, then you can plan the tapering of biologicals. How long you have to give the biologicals? So to prevent the structural damage, to prevent the radiographic progression, most of the trials have shown that if you are using a biological molecules for 4 years or more, then the chances of radiographic progression is less. If you are using for 6 months or 1 month, the chances of radiographic progression will be high. So in IL-17, regarding IL-17, we have secukinumab in India and ixekizumab, not available in India. This molecule is primarily used when there is associated psoriasis. This molecule is less effective in patients who are having uveitis and no effect in IBD patients. So there is a very rare risk of TB. So especially the medical professions who are having high active disease ankylosing spondylitis, this molecule is good because they have less TB reactivation, and the medical professionals are particularly exposed to TB in their day-to-day life. So now we have having the very common molecule that is being used is the targeted synthetic DMARD. So tofacitinib and upadacitinib has been approved, but we are having tofacitinib in our country. So the response can come as early as 1 week, ACR 20 response, ACR 50 as early as 2 weeks. So the patient pain and the global activity can be reduced as early as 3 days. So there are multiple screening tests. You have to also screen for viral markers, latent TB screening. Always take a history of malignancy, DBT, and pulmonary embolism. If there is any risk of serious infection, you have to always take this into account. So there are a common infection, adverse event. Infections are the one thing. Elevated cholesterol, CPK level can be increased because of tofacitinib. Hypertension and herpes zoster are must keep in mind before giving this molecule. So obviously we have these serious side effects like infections, malignancy, DVT, and pulmonary embolism. TB is an important risk factor. Major adverse cardiovascular event is an important factor. So you have to avoid tofacitinib in all these group of patients. So these are the FDA black box warning for the tofacitinib. So they are important poor prognostic factor for ankylosing spondylitis. If the patient is having this factor, you have to treat aggressively. Like if someone is having severe hyperarthritis, very high extraarticular manifestation, patient presenting with the dactylitis and having poor response to the NSAID, if persistent high inflammation in the form of high ESR and CRP, smokers patient are rapid progressors. If the patient age is less than 16 and male patient, they progresses rapidly. If the patient is having severe oligoarthritis and the early evidence of syndesmophyte formation. So these are the poor prognostic factors that you have to keep in the mind when you are planning a therapy. So now the refractory AS. If the patient is not responding to all of this therapy, you have to first confirm your diagnosis. Is it AS or something else? Rule out the AS mimics. You have to also rule out the psychological pain or fibromyalgia pain syndrome. So few drugs which has been, if there is inflammation and no other factors, then you can use the thalidomide, brodalumab, bimekizumab. And now the one important molecule that is very been discussed nowadays is anti-TRBV9 therapy. And it was found to be very effective in one patient, and it is given annually with 3 doses in patients. And the response is very good. So monitoring is very important key parameter when you are giving a patient any form of treatment, and there are multiple disease parameters which has been taken into account when you are giving a therapy. The ASDAS is the common score that we use to monitor when we give therapy to the AS patient. So overall the summary is that early treatment is very important. We have many of the people think that the AS should be treated later. Biologicals are should be kept for the latter period of disease when the diseases are very advanced. It is not so. So early treatment, prevent the inflammation, prevent the irreversible damage. Usually over the biological anti-TNFs are preferred over the IL-17. So which biologicals? It depends upon the multiple factors. So obviously we have to keep all the parameters in the mind before planning a biological therapy. How long? We have almost more than 12 to 15 years of data for the safety of biologicals, and monitoring is a very important parameter whenever you are treating a patient of ankylosing spondylitis. Thank you so much.
And our next speaker is Dr. Ishan Mishra.
Good evening. Greetings. So, all is not RA. So, my talk is made 90% easier by Kaushik Majani sir. I'll just continue with the same. RA is classically defined as a polyarthritis of symmetrical pattern, often involving the small joints. So, our differentials are based on that. You can divide the differentials into inflammatory and non-inflammatory. We'll discuss this one by one. So, SLE and connective tissue diseases. Like he said, arthritis plus. When you see arthritis plus symptoms, look for these diagnoses like Zika symptoms, skin rashes, Gottran signs and papules. They will point to a different diagnosis than RA. You can see the rash here, the Gottran sign, the Raynaud's phenomenon with gangrene, and palpable purpura. Coming to the next differential, which is spondyloarthropathy, beautifully discussed. So the peripheral manifestations usually can confuse you like RA. So like reactive arthritis, psoriatic arthritis, and IBD related arthritis, they can have peripheral arthritis as well. So the classical description of spondyloarthropathy joint involvement is asymmetrical, large joints below waist, with axial symptoms and obviously enthesopathies. When you compare it with RA, it is more or less symmetrical joints and small joints. The clues are, like he said, DIP joint involvement here, dactylitis, presence of psoriasis will give you the clue of other differentials. Coming to reactive arthritis, usually starts as a mono or oligoarthritis following a recent infection. Classical balanitis and this, what is called, I forgot. I forgot the lesion, what is called? Keratoderma. Keratoderma blenuragicum, yes. So, and coming to SP and IBD related arthritis, it is historically said two types of presentations are there. One is acute onset pauciarticular, usually involving knee. Type 2 is chronic persistent, more severe, and polyarticular. It may also have enthesitis and dactylitis. Sarcoid arthropathy is the one less common differential. It occurs in 10 to 15% of the patients of sarcoidosis. The acute arthritis, bilateral ankle arthritis with erythema nodosum and hilar lymphadenopathy is the triad, Lofgren syndrome. Chronic polyarticular presentation will be seen in 1 to 2% of the cases. The diagnostic clues will be high serum ACE level, and also dactylitis and Jacob's deformity can be seen. Less common differential, polymyalgia rheumatica, usually suspected when the inflammatory arthritis limiting to shoulder and hips, marked myalgias, very good response to glucocorticoids. Sometimes, very rarely seen in the settings of malignancy, remitting seronegative symmetrical synovitis with pitting edema. RF anti-CCP is negative, very rapid response to low glucocorticoid and some relation with malignancies. Nobody will confuse it with rheumatoid arthritis. It's still a differential, although when gout is polyarticular, some people may confuse it. Coming to infectious arthritis, these are usually self-limiting, resolve within 12 weeks, but can have a typical polyarticular presentation which is very similar to rheumatoid arthritis, as you are currently seeing in chikungunya arthritis. These are the list of the viruses that can cause. The most important in our country is chikungunya. The newer update is in the ACR this year there was an abstract which suggested that ankle tenderness and generalized stiffness is the unique characteristic of chikungunya arthritis. The chronic chikungunya arthritis will behave for all practical purposes like RA. Septic arthritis usually will be monoarticular. We will usually not confuse, but we should always do the synovial examination to rule to differentiate between the inflammatory and the non-inflammatory causes as well as the septic causes. Tubercular arthritis, usually the first differential of orthopedicians sometimes. We do not miss it, you do not miss it. The second most common presentation after the pot spine. Usually it is a monoarthritis, but there is a variant which is reactive arthritis variant. It is called Poncett's disease. It will present with ankle arthritis, usually ankle and other large joints, and it is usually non-erosive, always present in the presence of active pulmonary TB or extrapulmonary TB. and usually it resolves after few weeks of initiation of ATT. Manish sir is not here, but it's his favorite, Hansen's disease. It can also give, some presentations of polyarthritis, especially during lepra reactions. There can be chronic arthritis in leprosy. Also, neuropathic arthropathy, there is swollen hand and feet syndromes. All these have been described. Arthritis related to lepra reactions usually happen in type 1 and type 2 reactions, and it can be symmetric, it can be oligoarticular, it can be polyarthritis as well. The clues to diagnosis is obviously some hypopigmented macules, which there is no sensation, there is a loss of temperature sensation, and obviously the classic leprosy rash. There have been 4 and 5 major studies from India, and these are the various manifestations which they have seen in leprosy patients. Many of these patients have come out to be quite a minority only, but they are RF and anti-CCP positive. Diagnosis: high index of clinical suspicion, presence of thickened nerve with hyposthesia will clinch the diagnosis. Some arthritis is seen in the presence of paraneoplastic and cancer syndromes, like hypertrophic osteoarthropathy, especially in the adenocarcinoma lung. You can see the periosteal reaction around the bones. Some patients of myelodysplasia, even before the symptoms of myelodysplasia, will develop arthritis, and later on they'll go on and develop the myelodysplastic syndromes. Persistent anemia and cytopenia in the case of inflammatory arthritis should heighten the suspicion. In very rare cases, there can be a polyarthritis associated with immune checkpoint inhibitors which are used in the malignancies. Most cases are seronegative, and in some cases DMARDs have been tried. Coming to non-inflammatory causes, as Kaushik sir said, osteoarthritis. Classically, you see non-inflammatory joints with Bouchard's and Heberden nodes. Sometimes people do confuse with nodular OA of hand. There is clear-cut distinctions. There is usually MCP joint involvement is not there in osteoarthritis. There won't be or very less early morning stiffness, less than 15 minutes in osteoarthritis. The X-ray, there will be differences on the basis of the X-rays as well and the inflammatory markers. One common, this is stenosing tenosynovitis is also a common differential, but it can also be associated with RA. Carpal tunnel syndromes, as he said, can be confused with RA due to its classical distribution of the fingers in the median nerve. So also bilateral carpal tunnel can be seen in rheumatoid arthritis as well. Hypermobility syndromes can have polyarthralgia, so sometimes can be confused with RA. Fibromyalgia, always the last differential, but can be difficult to distinguish. Patient will have chronic widespread pain, multiple tender points in the body. Diagnostic clue is the presence of tender points at non-articular sites, and there will be associated sleep disturbances. This is just the gist of everything which I have said. I believe I have finished 5 minutes early. I'm done with this. Thank you.
Thank you, Dr. Misra, for illuminating our understandings. And our next speaker is Dr. Smruti Ramteke. May I request her to shed light on management of RA, current treatment recommendations.
Firstly, let me thank the organizers for calling me. And I would be speaking, probably there is a lot of overlap in the topics today, but I would be speaking about management of rheumatoid arthritis. So the reduction in time to treat, newer agents, and response-driven treatment is the new thing in rheumatoid arthritis, and with all this we have the improved outcomes. So the current treatment paradigm involves around three basic things: time to treat, treat to target, and targeted treatments. So rheumatoid is now a time critical illness, just like myocardial infarction. You are treating it urgently. Stroke, you are treating it urgently. And rheumatoid, we are waiting for years together to treat it. So it is now time critical. The first 2 years are very important because there is a high rate of progression, and if the patient is caught early on, they have much better results in terms of treatment as well as in terms of the mortality. Failing remission is the goal now, but failing remission, the next best goal is low disease activity. Ideally, the target should be reached within 6 months. 80% improvement in the disease should occur in the first 3 to 6 months. With the advent of new therapies like targeted treatments, biologics, and targeted synthetic DMARDs, this is very much possible now. So rheumatoid is a multidimensional disease. We have to see the different domains of the disease. Like when a patient is coming to you, how active is the disease? Is the patient disabled? How much is the damage? And what is the quality of life of the patient? So we have different validated tools to measure this. The various parameters to assess the disease activity are the early morning stiffness, swollen joint count, tender joint count, visual analog scales, the HAQ scores, ESR, and the NSAID pill count, how many NSAIDs the patient is taking per day. This is the DASC. This is the assessment of the swollen and the tender joints, and the various indices which we are using, the simplified disease activity index and the clinical disease activity index. So initially in 90s it was symptom relief. 1990, 2010 it was disease modification, but from 2010 we are thinking of remission. The classification of the drugs, you all know: NSAIDs, corticosteroids, conventional synthetic DMARDs, biologic response modifiers, the targeted synthetic DMARDs. NSAIDs, as doctor has already discussed, I won't go into the details of it, but the only thing is do not combine two NSAIDs. Each NSAID will have nephrotoxicity. Please keep that in mind, and whenever you are prescribing NSAIDs, please have a baseline renal profile of the patient. So they might be helpful in used in the rheumatoid flares. Non-selective NSAIDs are appropriate for patients at low risk for GI complications. Concern about the cardiovascular safety of COXIPs have led to revised recommendations. And in the elderly, in the absence of cardiovascular risk, COXIPs are preferred to non-selective NSAIDs. Corticosteroids, though they have a lot of stigma is associated with them, we use them in rheumatoid flares, in patients who have rheumatoid vasculitis, interstitial lung disease. They are also used as a bridge therapy, because whenever we are initiating DMARDs, it takes some time to act, and so in the initial part of the treatment, we might use it. And low dose corticosteroids may be used in patients who are refractory in pregnancy and lactation. The patient's steroids can be used safely. Now the use of disease modifying agents, early use should be done, The conventional DMARDs, the targeted DMARDs, biologic DMARDs, the biooriginator, and the biosimilars. These are the current nomenclature for DMARDs. So the commonly used conventional DMARDs are methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide. Now you all are using hydroxychloroquine, I suppose, and the only concern which women have with that is the skin pigmentation. So that is the commonest complaint which the patients have, and it is a safe drug to use. It can be used in pregnant women who have arthritis. We need to assess for retinopathy though. The baseline eye checkup should be done, and then yearly screening after 5 years of use. And automated visual field and spectral domain optical coherence tomography should be done. Sulfasalazine is safe in pregnancy, that is the most important thing. Now as Kaushik had said in his talk that talking with the patient is very, very important. So whenever a patient is coming to you with arthritis and she's a young woman and she's unmarried, we need to discuss marriage. We need to tell her that if she is on any of the drugs, what would be the safe option for her, and that is a very important part of management. So because usually women of childbearing age are coming to us and we need to see and assess what would be their next thing. Like if a patient has one child and she's not yet completed her childbearing, that needs to be discussed with the patient. So what is the usual problem with this sulfa drug? So you can have a sulfur allergy. So you have to tell the patient that you can have allergy. If you have any rashes, skin rashes, itching, please stop the drug, inform us. The routine monitoring is the blood count and LFT. So I request that you all should, if you are giving DMARDs, do the baseline, complete blood count, liver function, at least the SGPT and the creatinine of the patient before initiating any DMARD. That is very, very important. Second, talking with the patient is also very important. Methotrexate is the most widely prescribed conventional DMARD and is the anchor drug for treatment of rheumatoid, and it acts by inhibiting the dihydrofolate reductase. The usual dose is 7.5 to 25 milligram once a week, orally, subcut or intramuscular. Get a chest X-ray at baseline. Patient might be having underlying tuberculosis, patient may be having underlying interstitial lung disease. Use a stethoscope. How many of you are using stethos? None probably. But you need to examine the patient. Before you are starting on any of the DMARDs, maybe we just auscultate the patient and check if there is anything underlying. We might miss on it. The blood counts, liver function and the creatinine should be done. So why is methotrexate a drug of choice? The ease of administration, once a week dose, wide dose range 7.5 to 225, you can give anything in between. The route, it can be given orally, it can be given parenterally. Patient can take it by themselves. Even the injectable form is available subcut. You can train the patient, they can take it at home. It's compatible with all the other biologic DMARDs as well as the conventional DMARDs. And decades of experience. We know now what can happen to the patient, how we need to monitor. Folic acid needs to be given with methotrexate, and someone might use it daily except on the day of methotrexate, or once a week also is sufficient. So oral dose more than 15 milligram, you can split it into 2 doses and space it out at 12 hours to improve the absorption. If the patient is on 15 milligram oral and is not getting better, maybe we shift the patient to injectable methotrexate. Methotrexate induced ILD is rare, but hypersensitivity pneumonitis is also rare but can happen. So whenever prescribing methotrexate, tell the patient that if there is any cough which is recent onset or breathlessness, please report. So bone marrow suppression, hepatotoxicity, hypersensitivity, pneumonitis, for which I said ask the history of cough or breathlessness. Tell the patient that if you have new onset cough or breathlessness, please report. Mucositis, the oral ulcerations, nausea and hair loss are few side effects. We need to regularly monitor the patient. The blood counts, liver function should be done. If the patient is alcoholic, you have to tell them, ask them to stop alcohol. So that is important. Please ask the history of alcohol intake. If the patient is alcoholic, he is susceptible to liver damage with methotrexate. Please ask the history. If the patient has poor renal function, if the creatinine is high, this patient will have methotrexate in his blood and there will be more toxic effects as compared to normal. So checking the underlying baseline creatinine, checking the baseline SGPT, asking the history is important. So females should be asked that if you are planning another pregnancy, you have to stop this medicine. Now there is the mark is there over the tablet. They have to stop it at least 3 months prior to conception. Males can continue the drug, and the caution is there for alcoholics. Leflunomide is a tyrosine kinase inhibitor, and the dose is 10 to 20 milligram, but monitor the liver function. And when combining methotrexate and leflunomide, please be aware that this patient can have liver toxicity. So give it to a patient who can follow up regularly. Don't give it to some patient who is not going to see you for another 2 years. and then lands up with raised liver enzymes and problems. So these are the common side effects. The most important thing is it stays in the blood for 2 years. So you need to, if a young girl comes to you, you can't give her leflunomide. If she's not yet conceived, please don't give her leflunomide. If she has not completed her family, please don't give her leflunomide. So the very important thing is talk with the patient, ask about her pregnancy, ask whether she has completed her childbearing, ask whether she has completed her family. So if she wants to conceive, we have to give a washout of cholestyramine, and then she can conceive after checking the leflunomide levels. Now combination therapy, you can use all these drugs in combination, methotrexate, leflunomide, and but liver toxicity is the thing which stays. And now about biologics in short, the targeted treatment comprise biologics and the targeted DMARDs. Biologic therapies are genetically engineered treatment like monoclonal antibodies or receptor fusion proteins. These are the different biologic DMARDs. Now here you can see that this is the antigen presenting cell which stimulates the T cell. Abatacept is a molecule which acts on the T cell. Rituximab acts on the B cell. Anakinra blocks IL-1. And tocilizumab blocks the IL-6. And then there are the TNF-alpha inhibitors, etanercept, adalimumab, infliximab, etc. So I won't go into the details of it. But these are the different TNF blocking agents, and they have a different mode of administration. Infliximab is given IV, the rest of them are subcutaneous injections given at different intervals. So when to initiate a biologic in RA, inadequate response to conventional DMARDs. If the disease is very aggressive with poor prognostic factors, there is an intolerance to conventional DMARD. So if a patient is on doesn't even tolerate a 5 milligram dose of methotrexate, cannot be given leflunomide because she wants to have children, and sulfasalazine is very mild for her, then maybe we give the patient biologics or oral DMARDs or injectable DMARD at the onset. And special situations where the rheumatoid is very aggressive, there is corneal melt, rheumatoid vasculitis, rheumatoid ILD, and not being controlled on the routine drugs, can be given biologics. Now the screening for biologics is very, very important. Let me tell you, do not initiate any biologic without screening. HBsAg, HCV, HIV needs to be done. Screening for latent TB needs to be done. Montux needs to be done. IGRA, if it is available, should be done. Chest radiograph and a baseline lipid profile. So they are not the molecules to be taken lightly. We need to investigate. Baseline investigations are a must before starting any biologics. They help control the disease, they reduce signs and symptoms, they improve the quality of life of the patient, and they are superior than methotrexate in inhibiting radiographic progression of the disease, and in combination with methotrexate, they are excellent. Which biologic for whom? Now in the absence of biomarkers, we do not have biomarkers at our place right now to tell which biologic is going to suit this patient. So more or less it's more of empiric. It's the patient preference, the physician's familiarity with the drug, availability of the drug, cost of the drug. Cost is the most important factor in our setup. And many times we give tailor-made therapy, like a patient who is taking adalimumab once in 15 days is the recommended dose, but after he gets better, we give it once in 3 weeks, once in 1 month, and then later on once in 2 months, and the patient is doing well. So that is empiric. There's nowhere is it written in the books, but we are giving it as per the need of the patient and his pocket. Again, the cost is an important factor. Insurance, avoiding daycare, hospitalizations. Few patients do not want to be hospitalized. And taking the drug on your own, like self-administered drug, these are the, if someone prefers that, we give them. So these are the different drugs. Golimumab once a month is effective. Rituximab can be given. So the side effects are infusion related reactions like the local injection, demyelinating diseases, serious infections, especially activation of tuberculosis, sepsis, malignancies, lymphomas, solid tumors, and pregnancy stopped before conception, and no live vaccines should be given. So infection risk, activation of mycobacterium, screening I already told, and hepatitis B and C can be reactivated. Do not start, again I am saying this, do not start biologics without screening the patient, without doing appropriate investigations. Tomorrow if the patient lands up in sepsis and goes on ventilator, you will be asked why the baseline investigations were not done. Tomorrow if the patient has a reactivation of hepatitis B, you will be asked why the baseline investigations were not done. So be safe than sorry, that's better. So I would be speaking about this Janus kinase inhibitors, that is the JAK inhibitors, tofacitinib, baricitinib. I'm so sorry. So side effects of tofacitinib. So FDA has now required updated warning regarding an increased risk of heart attacks, blood cancer, stroke and blood clot for JAK inhibitors. This is September 2021. Tofacitinib and baricitinib increase the LDL levels, but they have said that this is probably not of negligible impact on the cardiovascular risk, but we have to observe it with caution. The incidence of venous thromboembolism ranges from 0.3 to per 100 patient years for upadacitinib. Rate of malignancy among JAKI is 0.7 to 0.9, and non-melanoma skin cancers have been reported with tofacitinib. Please do not forget this. Before using anything right and left, we need to be aware that this is not, though there is a 10 years old trial with tofacitinib, still we are not aware completely of what is happening in our population. So we need to be careful. So if a patient who has had history of pulmonary thromboembolism, please do not start tofacitinib. So the history needs to be asked to these patients. Now, methotrexate, leflunomide, mycophenolate, JAK inhibitors are a no-no for patients who are planning pregnancy. Sorry.
Please conclude, madam.
Yeah. So I would skip this. So basically the crux of it is that most of the biologics need to be used with caution, and then the patient needs to be investigated before using them. And secondly, in rheumatoid arthritis, now we are thinking of remission. So it's better to treat the patient aggressively from the beginning. But please, before treating the patients, get the baseline investigations, talk with the patient, look at the overall profile of the patient, and never forget to ask the patient whether she's married, she has 1 child, 2 children, what she's planning regarding childbearing. Thank you so much.
Thank you, madam, for enlightening us and for emphasizing on the use of a stethoscope. I would rather tell that you should also use the stethoscope of the musculoskeletal system, like musculoskeletal ultrasound for the early diagnosis.
Yeah, that's true.
Also in RA, also in spondyloarthropathy, and for decreasing the differential, it also helps in decreasing the differentials and guided interventions. And yes, sir. What, sir?
Your
Yes,
history
yes,
and clinical examination cannot be substituted by instruments. Period.
Yes, sir.
I am very, very clear about it, boss, and I will agree, I will argue for it till I am alive. What are we doing? We are just talking about technology, then we don't need it. Why don't you just put a gene chip and say, okay, ye dawai de diya? Doesn't work. Does not work. Do you want me to show you all the examples for a 2.5-hour conference only for me, where I show you all the wrong diagnosis made because of MRIs, because of ultrasounds and so on?
I agree, I totally agree. It may misinterpreted, sir, but let me tell you, in rheumatological practice, more than 90% part is history and clinical examination. And what I am telling you, sir, or you all, it's not an investigation. it's an extension of clinical examination. And when you precisely use its extension of the clinical examination, really, let me tell you, many of the early diagnosis, and in rheumatology, it's all plays of all the early diagnosis. Like a spondyloarthropathy, earlier we used to diagnose, it takes 10 years. But nowadays, like patient is a mild early morning stiffness. If you scan the Achilles tendon, you will scan the plantar fascia, you will see the MRI ultrasound will predict the early diagnosis. It will help. It will decrease your differential rather than, and so on. Yeah, yeah. Yeah, but clinical, sometimes it becomes subjective. Patient, because all pain is very subjective matter, sir.
The beauty is
Yes, sir,
clinical examination. You cannot change that period.
I totally
And
agree, sir.
I will prove it to you. You cannot go
I can
around
discuss
writing
on
random MRIs.
days and months, but I request delegates to please come up with your questions.
Random
so that we
MRIs,
can
random ultrasounds
yes,
being
sir.
written, wrong diagnosis and wrong treatment being given. I could
Even
take
MRI
you
is
through a whole
reported
session.
wrong. Even MRI is reported.
Exactly.
Ultrasound has very high learning curve. Very high
Clinical,
learning curve.
clinical.
Yes,
It's all
yes.
clinical.
I request delegates to please ask the questions so that we can come to like for
After
the
the
purpose of
nice and
conferences.
heated debate, I have a simple question. We all have emphasized the eminent speakers on early clinical diagnosis, starting aggressive treatment. Question is how long the treatment should be continued, especially in ankylosing spondylitis where we find that remission is quick, is prolonged, then how long do we need to keep the active treatment?
I was going to come to that slide, but however, 15 minutes are very short for covering treatment of rheumatoid arthritis, I believe. So the thing is, once the remission has been achieved, maintain the remission and slowly after maintaining the remission for certain times, try and slowly reduce the medicine. Maybe some patients we can stop it, but few patients we have to continue the low doses for life.
Like in one of the slides, Dr. Rajeev showed that if you continue the drug for 4 years, then the chances of radiological and clinical deformity is less. So does that mean that even after complete remission and pain relief, do we still continue the drugs for 4 years?
Yes, that is very true. For a spinal radiographic damage prevention, you have to keep the biological for long term. Most of the studies, most of the trials, those who are used biological drugs for less than 3 years or 4 years, the spinal radiographic progression is not significantly different than the placebo. So it's very important even for the secukinumab and anti-TNF, you have to use the molecule for the long term, even after remission. Yes, but after, if the patient is in remission, give the molecule for sustained remission. Sustained remission is a concept where you give the molecule for 6 to 12 months and patient is remission for 1 year after the remission. And if the patient is in sustained remission, you have to either increase the duration of biologic or maintain the remission. And if you are using this biological, there is no such guideline ki how much years you have to give. But yes, for long-term spinal radiographic prevention, you have to use for long-term. At least minimum for 4 years.
I normally take these papers and trials with a pinch of salt. I think most of it is industry and pharma driven where they want you to continue for longer and longer duration. Whereas with minimal patient benefit,
we have
more
many patients
toxicity.
who just stop the medicine on their own.
Yeah.
And then they come back to us and then they say that, yeah, I have been fine for all these 8 years or
Yeah.
5 years or 3 years. And they teach us that sometimes the disease has gone into remission and the patient was cured and then again it has come back.
Sure.
Ma'am, many a times we find that disease progression is not there, no joint is tender, but patient left the drug treatment of methotrexate or whatever we are giving oral medications. Then again there is pain. They come back with pain और कोई arthritis का कोई features नहीं है, न swelling है, न redness है, न tenderness है, बस pain of the joint and others. No early morning stiffness also. Then what to do?
And what about the inflammatory markers?
Almost
So
near normal. You
then
can say.
that pain needs to be analyzed, whether it is the pain of arthritis or it is fibromyalgia or some soft tissue rheumatism like thing. We need to see that. And the patient, usually what happens in rheumatoid is, it's like the disease is never quiet. It's ongoing. So by and large, the patients will If they have received adequate treatment and the patient is in remission, that's a different story. But patient is going to have some disease activity ongoing. So that needs to be taken, but as you have said, this looks like the patient might be having some fibromyalgia-like thing.
I think you will discuss it tomorrow.
Yeah.
Thank you. Thank you.
Excuse me. When and why we use the corticosteroid or the biological agent? Which is better? Which have the advantage? Which have less toxicity?
Corticosteroids is no comparison to biologic agents. Corticosteroids is reserved for patient like a patient who is pregnant. We cannot use much. So that patient we can use corticosteroids.
Why we not use in every patient?
Why should we use it in every patient?
Yeah.
When we have so many.
Where DMRD is not working properly.
So if DMRDs
then
are
we
not
choose something else. Then
So
why biological agent? Why not corticosteroids? My question is that.
because corticosteroids have long-term side effects. You know that the patient becomes dependent, his HPA axis is suppressed, he will become dependent for life. After 5 years, if you want to stop it, it's a hell of a job. You cannot stop it after 5 years.
Biological agent also have the higher.
No, but they don't make you dependent. Biologics are not making you dependent. Like if I stop methotrexate, the patient is not going to experience. Then if you open the Davidson book, there is the full page of what corticosteroids can do to you. Like if I give you an option that you want to use disease-modifying agents or corticosteroids for yourself, what will you use? Definitely you're going to prefer using disease-modifying agents or some of your family member. Why use corticosteroids when there are n number of drugs available? They can be used. Like a patient has renal dysfunction, I can't use methotrexate, I can't use leflunomide. A small dose of corticosteroids can be used in patients where we have multitudes of problems, but not in every patient. That patient might be like, out of 100, there might be 2 or 3. In the initial part of the disease, yes, as a bridge therapy for 6 weeks, 8 weeks, that's fine, but not in every patient.
I got the answer that we can use intermittently whenever there is acute exacerbation
We
of
can
the
also
chronic.
use NSAIDs.
When you consider biological agent?
If the patient is not responding to 25 milligram of methotrexate, plus patient is on leflunomide, plus patient is on sulfasalazine, 2 or 3 drugs are there, patient is non-responsive, that is the time when you should think of biologics. Second, if a patient has some side effects with the conventional DMARDs. So as I said, if the patient wants to have a child, we can't give her leflunomide. Second, if the patient is not tolerating methotrexate, then I don't have other options. So I need to control the disease. Then we can go for biologics.
Then you stopped all DMRs and start only biological agent?
Yeah.
No adjoining them?
No, the better thing is to give both the things together if the patient is non-responsive. But if the patient is not tolerating conventional DMARDs, go for biologics.
Okay, thank you.
Thank you.
Now, session is concluded. Thank you all speakers.
Our celebrity has arrived today, DGP of Bihar, Mr. Alok Raj.
Very good evening, everyone. So, a packed house on a rainy evening. We have had very good 3 sessions, very elaborate talks regarding rheumatoid arthritis, and it's only the beginning, and tomorrow we shall have even more detailed discussions on various aspects of rheumatology. So, beginning with the inaugural function for today's evening, we welcome our guests over here, and I would like to call upon stage the President of Bihar Orthopedic Association, Dr. Anil Kumar sir, for a few kind words. He was very early, he came to the hall and he was all throughout present, encouraging us and participated wholeheartedly. Please come on the dais, sir, and bless us with a few words.
Good evening, everyone. Our chief guest, Sri Alok Raj, President Aarcon, Dr. Sarsis Nenam, all the dignities, and ladies and gentlemen. We have gathered here on 10th Aarcon conference discussing about arthritis. Different arthritis we have already discussed, and still one day has to go. Type of arthritis, diagnosis, treatment, etc. we have all discussed. I think all of us will learn something out of this. I congratulate Dr. Amuli Kumar Singh, the dynamic organizing secretary, and I wish all the best and grand success of the conference. Thank you very much. Thank you, sir.
Thank you so much, Dr. Anil Kumar sir. We'll give you trouble once more for the inaugural function. We'd like to invite you once again, so please stay within the hall. And we also have with us the secretary of BOA, Dr. Praveen Sahu sir, with us. A few words from him as well.
Very good evening to all of you and all the dignitaries, audience and orthopedic surgeons, all the faculties coming from outside. We are really proud that this type of event is being done regularly by Aarcon team, and Dr. Amuli Kumar Singh sir takes a lot of pain in organizing such event. Although we are orthopedicians, we all are dealing with the joint diseases, and we were initially feeling too much difficulty in selecting the drug, and we were largely unaware of the newer drugs which have been invented and being under the treatment. And most of the patients had to go outside the Bihar. But this kind of event regularly being done for last few years has been improving the outcome of rheumatoid arthritis patient in Bihar, and we are lucky to have this conference and this type of conference here in Bihar. And we are really proud of Dr. Amuli Kumar Singh sir, that he is very much innovative in doing all these things. And not only he is doing the conference, he is using all the newer drugs like etanercept, adalimumab for many years, and we are really thankful to him that he is advocating to go for the newer drugs, because these have their own advantage. When these primary drugs fail, we usually, our patients from Bihar usually had to travel along to Delhi, Calcutta and metro cities, and they had to spend a lot of money and take a lot of pain, and most of them become disabled. Now disability are being minimized, and this type of conference will definitely enlighten all the orthopedic surgeon, and we will be able to treat it more vigorously. Thank you, sir. Thank you all.
Very articulately explained the significance of this conference, Dr. Praveen Sahu sir. We thank you so much. Now for the real inauguration, I'd like to call upon stage. We are lucky to have with us the chief guest, the DGP of Bihar, Mr. Alok Raj sir. Please come on the dais, sir. Dr. Anil Kumar sir, the President BOA, Dr. Praveen Kumar Sahu, Secretary BOA, Dr. Professor S.S. Jha sir, please come on the dais. Dr. Sarsis Nainam sir, the President of Global Orthopedic Forum, Dr. Jivendu Chaudhary sir, please come on the dais. The man behind the show, Dr. Amulya sir, and a very senior orthopedic surgeon and a father figure, Dr. R.R. Kanojia sir. Please come on the stage for the inaugural function.
वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्डमहाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
सिंदूर लाल चढ़ायो अच्छा गजमुख को, चोंदिल लाल विराजे सुत गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को। जय देव जय देव।
Thank you so much. Thank you so much, all the guests. I'll request DGP Alok Raj sir to stay back and will request all other guests to please take their respected seats. Please take your respective seats. And now we proceed with the next part of the inaugural function. We have so many of esteemed faculties from various parts of India who've taken all the pain to be amongst us and to enlighten us with their vast knowledge. And I request DGP Alok Raj sir to felicitate our guest faculties, and I'll request them to come one by one on the stage as I call their names, and our guest, our chief guest shall felicitate them with a shawl and a lapel pin. Dr. Raj Kiran Dudam, please come on the dais, sir. It was a very elaborate discussion that I think Dr. Amulya sir from Hyderabad. He's traveled all the way from the city of Charminar. A wonderful talk and wonderful interactive sessions following his talk as well. Volunteers, please be ready. Thank you, sir. Next, I'd like to call upon stage Dr. Kaushik Bhojani, sir, who is from Mumbai. Again, an excellent insight into how we can go wrong when it comes to diagnosis of RA and how various diseases can mimic RA and what are the precautions we should take while diagnosing RA. A wonderful talk. Thank you so much for traveling all the way from Mumbai, sir. Thank you, sir. Next, I'd like to call upon stage Dr. Smriti Ramtake, ma'am.
She's from Nagpur. Thank you, ma'am. Basically, all the faculties are the best possible friends of our reception committee chairperson, Dr. Manish. Unfortunately, because of his illness, he was here for some time. He has just recovered from his illness, recovering, I will say. So we are missing him at present. So we are thankful to all of you that you have made it to Patna. This is the lapel pin of our Global Orthopedic Forum, ma'am.
Thank you, ma'am. Next, can we have Dr. Shyamasish Bandopadhyay? Sir, please come on the dais.
Dr. Shyamasish has reached Calcutta, but he has not come just now.
Okay.
He has reached, Chanakya Hotel.
Okay.
His flight was slightly late. Maybe he will be coming after some time.
So, Dr. Kavita Krishna, ma'am,
Yeah.
I request you to please come on the stage.
She has come from Pune, from where I did my MBBS AFMC. But I left army, came back to Patna. Dr. Kavita, she came yesterday. Sir, Mr. Alok Raj, sir, she went to Nalanda, Rajgir. She covered most of the part. And in one day, she has made it.
Thank you so much, ma'am. Next, amongst our esteemed faculties is Dr. Rajiv Ranjan Kumar. Sir, kindly be on stage.
Dr. Rajiv is from Delhi. And right from morning is busy. I must have, I know that you have seen more than 100 patients today in Patna. But we are lucky that you have blessed us. Thank you, Dr. Rajiv.
Next, can we have the pleasure of your presence, Dr. Bindhyachal Kumar
Dr.
Gupta?
Bindhyachal is in train.
He
will be reaching at around 9:30, 9:45.
Dr. Ishan.
Dr. Ishan is here. He is from Varanasi. A very young person, dynamic, and we are thankful to you that, Ishan, you have made it.
Thank you so much, Dr. Ishan. We also have with us a very renowned dental surgeon from Patna. Amongst us is Dr. Sanjay Santhalia, sir.
Sanjay, please.
I request you to please come on stage, sir. You've been so active in all social circles. And one thing I suppose many of you might be knowing and many might not even be knowing, that both Dr. Sanjay Santhalia sir and DGP Alok Raj sir, they are very fond of music. They have a great music club. Even Dr. Amulya sir is there. But Alok Raj sir is so fond of music. In fact, he has taken some formal trainings also. He has his albums, private albums as well. A great singer, a great singer. And all three of them in the frame are great friends as well.
Thank you, Sanjay. Thank you, Sanjay, so much. And another thing is that our respected DGP, he became DGP just now, but his song came in the movie last year only. So yes, he was there in the playback song as a singer in one of the Hindi movie. So he's a reputed fame, and he does his own, basically he is invited to so many places, lots of places he has been invited for his solo performance. He's a wonderful singer, but here naturally I'm here inviting as a chief guest, not as a singer. So we are privileged to have him.
Do we have Mr. BD Singh with us?
He is on the way, sir.
Okay. So moving on with the next section, the guest speakers, the chairpersons, we would like to, the moderators, Global Orthopedic Forum would like to felicitate them with mementos and in the form of beautifully crafted certificates. For this, I'd like to invite Dr. Vikram Veer. Dr. Vikram, a
Dr.
very
Vikram
young,
Veer.
dynamic orthopedic surgeon.
Thank you, Dr. Vikram. Right on time he started. We planned to start at 6:30 and he made it that we started at 6:30.
Dr. S.P. Gupta, sir.
Dr. S.P. Gupta, sir.
Always very punctual. One of the first members to attend amongst the delegates in any of the orthopedic conferences.
Dr. S.P. Gupta, sir.
Can anybody guess his age? Exactly. Sweet 16 he is.
Thank you, sir.
Dr. Anup Kumar, I think he just left. Dr. Anup Kumar, Professor.
Dr. Professor Anup Kumar.
He has left.
He has just left because.
Colonel S.K. Singh.
Dr. Colonel S.K. Singh.
S.K. Singh from Medanta. Doing excellent job. He's made his mark all round. Please come.
And Dr. Anup is Professor and HOD of AIMS. Unfortunately, he left about 10 minutes back because of his personal work. Colonel S.K. Singh is in Medanta Hospital, orthopedics.
The next on the list is somebody for whom I'll ask the audience for a personal extra round of applause. My bosom friend, Dr. Firoz Alam, my all-weather friend, is always with the organizing team. Dr. Amulya sirs.
Dr. Firoz has come all the way from Gopalganj, big practicing surgeon at Gopalganj, Siwan and all that area.
And both of us are very fortunate to have been at the receiving of so much of affection from Dr. Amulya sir. Dr. Gurudev, are you still here?
Dr. Gurudev.
Dr. Gurudev is a busy orthopedic surgeon and arthroscopic surgeon. He must have left. Dr. Arvind Gupta is also left. Dr. Abhishek Das, you were here. Dr. Abhishek, very actively participating. I think he is also left. Dr. Bipul Prakash Singh, sir.
Dr. Bipul.
From Gopalganj. We have very fond memories of you, sir. When Dr. Amulya sir was the organizing secretary of Aarcon, and Aarcon was held at your place, we have really very fond memories of your place. Dr. Bipul Prakash Singh, sir. Our Guru, Dr. A.K. Manav, sir. He has been my teacher at PMCH. Please come on the dais, sir. Dr. Kamrul Hoda sir, retired from PMCH, doing his practice in Fulwari, visiting faculty at a medical college in Saharsa. Thank you so much for sparing time, sir. Dr. Kanhaiya Singh sir, I think he hasn't made. Okay. Dr. Arvind Kumar Singh sir is also not here. Dr. Vikas, any conference seems incomplete without your relentless efforts, always active in garnering delegates, getting registrations done. Thank you, Dr. Vikas, for all your active participation. Dr. Brajesh sir, I saw you. Yeah. Dr. Brajesh Kumar Singh sir, a very senior orthopedic surgeon.
Hello.
Dr. Madhusudan sir, I think he is not here. Dr. Madhusudan. Dr. Rajkumar.
Chick. Low. Chick.
Dr. Rajkumar, yeah.
Low. Chick.
Dr. Rajkumar is a good swimmer also. We have seen his swimming skills and the Ganges. HOD, IJMS.
Hello.
Dr. Kumar Shashikant, are you here? No. So, next I'd like to invite Professor S.S. Jha sir to honor and felicitate our chief guest, DGP Bihar, Mr. Alok Raj sir, with a bouquet. Dr. Sarsis Nanam sir, to please present him with a shawl. Dr. R.R. Kanojia sir, to please present him a lapel pin. Dr. V.K. Thakur sir, please present a memento to our chief guest. Indeed, Global Orthopedic Forum takes so much pride in having all you stalwarts in a single frame.
Check.
Now I request our chief guest for a few words, please.
Hello. चूँकि मैं ऐसे फोरम पर बोलने का अभ्यस्त नहीं हूँ, तो मैंने सोचा कुछ लिख लेता हूँ ताकि कुछ सार्थक बातें कह सकूँ और निरर्थक बातों से बच सकूँ। अक्षत सेवा सदन के तत्वाधान में संचालित ग्लोबल ऑर्थोपेडिक फोरम द्वारा आयोजित आर्कॉन के इस सम्मेलन में उपस्थित सभी आदरणीय अतिथिगण, वरीय चिकित्सक, शोधकर्ता एवं इस कार्यक्रम में उपस्थित सभी विशिष्ट जनों को उनके द्वारा नागरिकों के कष्ट निवारण के दिशा में किए गए प्रयासों के लिए मैं साधुवाद देता हूँ। कष्ट निवारण मैं इसलिए कह रहा हूँ कि आर्थराइटिस या रिमेटोलॉजी जो एक समस्या है, हम लोग सभी उससे अवगत हैं। मुझे खुशी है और मैं आपका आभारी हूं कि आपने मुझे यहाँ आमंत्रित किया और बिहार के पुलिस महानिदेशक के तौर पर मेरी उपस्थिति इस बात का प्रमाण है और इस बात की पुष्टि करता है कि संपूर्ण बिहार पुलिस चिकित्सकों द्वारा, डॉक्टर्स द्वारा किए गए सामाजिक कार्यों के प्रति, ये हमारा सभी डॉक्टर्स के प्रति ये बिहार पुलिस का सम्मान है और इस सम्मान के प्रतीक के रूप में यहाँ आया हूँ। ऑर्थोपेडिक्स एक ऐसी समस्या है कि मैं व्यक्तिगत रूप से इसको देख रहा हूँ, क्योंकि मेरे फादर डॉक्टर अमूल्य जानते हैं, ही इज़ नाउ अबाउट 85 ईयर्स, उनका दोनों नी में बहुत सीवियर प्रॉब्लम है। डॉक्टर अनिल भी जानते हैं पापा को, और कई जगह हमने दिखाया भी, बट सब लोग बोलते हैं कि इट्स एज रिलेटेड। सभी लोग यहाँ बैठे हुए हैं, तो मुझे लगता है कि ये जो समस्या है, आप जो इस फोरम में जो बातें कह रहे हैं, मैं पूरा लेक्चर सुना नहीं, लेकिन मुझे ये लगता है कि ऑर्थोपेडिक्स चिकित्सा का एक ऐसा क्षेत्र है जिसमें चिकित्सा के साथ साथ लाइफ मॉडिफिकेशन की भी आप ट्रेनिंग देते हैं, हाउ टू मॉडिफाई योर लाइफस्टाइल। और ऑर्थोपेडिक्स के लिए आवश्यक भी है, क्योंकि हड्डियां, जोड़ों और जो मांसपेशियों या जो नर्व से संबंधित बीमारियां हैं, या तो स्वाभाविक रूप से हो सकती हैं या किसी एक्सीडेंट के कारण भी हो सकती हैं। आज विज्ञान की तरक्की के कारण, चिकित्सा क्षेत्र में हुई प्रगति के कारण कई लोग विभिन्न ऑपरेटिव सर्जरी के माध्यम से, विभिन्न तकनीक के माध्यम से अच्छी जीवन शैली व्यतीत करने में सफल हो रहे हैं। मैं आपके सामने खड़ा हूं, यह भी एक ऑर्थोपेडिक्स का ही मुझे कहूँगा देन है, क्योंकि ईयर 1999 में मैं जब बोकारो में पोस्टेड था तो मेरा मेनिस्कस का टीयर हो गया था। 99 की बात है। तो मैं एक एक्टिव पुलिस ऑफिसर अभी भी हूँ, उस समय तो एसपी रैंक में था, लंबी सर्विस बची हुई थी, तो मुझे लगा कि ये तो मेरे ज़िंदगी में बड़ा बदलाव ले आएगा, बड़ा ठहराव आ जाएगा। तो मैंने कुछ चिकित्सकों से सलाह लिया, मैं बोकारो से रांची गया, फिर रांची से पटना आया, तो सभी लोगों ने कहा कि भाई इसका तो 2 ही इलाज है, 3 इलाज है। एक इलाज है प्रिवेंट, जो आप कहते हैं, जो ट्रेडिशनल इलाज है कि आप धीरे धीरे फिजियोथेरेपी करके और आप एक्सरसाइज करके ठीक होइएगा, लेकिन वो लंबा प्रोसेस है और आपके लिए ठीक नहीं है, क्योंकि आप एक्टिव पुलिस ऑफिसर हैं, आपको दौड़ना, भागना है, कूदना है, आपके लिए वो रूल्ड आउट है। अगर मिडिल एज के बाद किसी को होता है 60s में, तो 70s में, तो हम लोग एडवाइस करते हैं। दूसरा इलाज है ओपन नी सर्जरी। अच्छा, उस समय ये भी नहीं क्लियर था कि मेनिस्कस है कि वो क्रुशेट लिगामेंट है, जिसको AXL बोलते हैं टेक्निकल भाषा में, ACL। हाँ, तो मुझे किसी ने कहा कि बॉम्बे में एक डॉक्टर है, डॉक्टर अनंत जोशी, जो आर्थोस्कोपिक सर्जरी करते हैं इसका। ये 99 की बात है, ये सोचिए, इतना 25 साल हो गया, पर उनसे टाइम नहीं मिलता है, इज अ वेरी बिजी डॉक्टर। तो मैंने कहा कि भाई पुलिस ऑफिसर हूँ, कोशिश करता हूँ टाइम लेने की, लेकिन पुलिस के थ्रू टाइम नहीं मिला उनसे। फिर किसी ने बताया कि वो क्रिकेट कंट्रोल बोर्ड के डॉक्टर हैं, वहाँ से कोई अगर आपको कोई हेल्प कर देगा तो आपको तुरंत टाइम मिल जाएगा। तो मैं उस समय क्रिकेट एसोसिएशन में भी था बिहार में, तो उस माध्यम से मैंने डॉक्टर जोशी को अप्रोच किया, तुरंत टाइम मिल गया और मैं बॉम्बे चला गया। बॉम्बे उनके क्लिनिक में गया, अंधेरी या कहीं क्लिनिक था, मुझे याद आ रहा है, उन्होंने कहा कि बॉम्बे हॉस्पिटल में तुम्हारा ऑपरेशन करेंगे। वेरी स्मार्ट हैंडसम मैन। और मैंने कहा कि ठीक तो हो जाएंगे ना? बोले नहीं नहीं, 2 दिन में दम ठीक हो जाओगे। ऑपरेशन हुआ, 2 छोटा छोटा उन्होंने हैंडी प्लास्ट टाइप का लगाया नी पर। सेकेंड डे मुझे डिस्चार्ज हो गया मैं। उसके बाद मैं रहा 3-4 दिन वहाँ पुलिस मेस में, फिर मैं लौट के आया। देखिए आज मैं आपके सामने बिल्कुल खड़ा हूँ। तो थैंक्स टू डॉक्टर अनंत जोशी एंड थैंक्स टू ऑल द डॉक्टर्स। तो मैं ये कहना चाहता हूँ कि होता यह है कि कई चीज़ें हमारे कंट्रोल में नहीं होती हैं। जैसे एज रिलेटेड जो ऑर्थोपेडिक समस्याएं हैं वो हमारे कंट्रोल में नहीं होती हैं। उसी तरह से एक्सीडेंट्स भी हमारे कंट्रोल में नहीं है। आदमी चलता है, स्लिप करता है, उसको फ्रैक्चर हो जाता है। लेकिन आज जो विषय पे आप बात कर रहे हैं, मैंने थोड़ा इसके बारे में अध्ययन किया तो मुझे पता चला कि भारत में रिमेटॉइड आर्थराइटिस से प्रभावित लगभग 0.7% लोग हैं 2020 के आंकड़ों में, अर्थात लगभग 1.5 करोड़ लोग इस गंभीर बीमारी से ग्रस्त हैं। ये मैंने पढ़ा। और एक औसत अनुमान के आधार पर पूरे विश्व में इस बीमारी से लगभग 17-18 करोड़ लोग पीड़ित हैं। और एक अनुमान है कि 2050 तक ये जो 17-18 करोड़ की जो संख्या है ये बढ़कर करीब 32 करोड़ हो जाएगी। अर्थात प्रति 1 लाख जनसंख्या पे लगभग 208 लोग इस बीमारी से ग्रसित हो जाएंगे। ये कोई WHO का कोई जर्नल था जिससे लिया गया। भारत में और विशेषकर बिहार में इस बीमारी के इलाज की कई चुनौतियां हैं। आप सभी जानते हैं कि हमारे जो राज्य है यहाँ कई ग्रामीण इलाके हैं, दूरस्थ इलाके हैं जहाँ हाई लेवल ऑफ ट्रीटमेंट या उच्च स्तरीय इलाज की दिक्कतें हैं, मुश्किलें हैं। पर मुझे बड़ा अच्छा लगा जब मैंने देखा कि गोपालगंज से लोग आए हैं या बिहार के ऐसे ज़िलों से लोग आ रहे हैं, डॉक्टर्स वहाँ प्रैक्टिस कर रहे हैं, अच्छा कर रहे हैं। जो रूरल एरियाज़, जहाँ गोपालगंज में काफ़ी बड़ा एक रूरल एरिया है। तो मुझे डॉक्टर अमूल्य को मैं ये कहना चाहूँगा कि आप जितना बिहार के रूरल एरिया में इसको प्रमोट करा सकते हैं, प्रोपेगेट करा सकते हैं अपने फोरम के माध्यम से, तो ये बहुत बिहार की आम जनता के लिए बहुत लाभदायक होगा। वर्तमान समय में इस रोग के इलाज के प्रावधानों में कई शोध और नई तकनीकें सामने आई हैं, जैसे बायोलॉजिकल थेरेपी, आर्टिफिशियल इंटेलिजेंस से इसके ट्रीटमेंट में हेल्प हो रहा है। और ऐसा माना जा रहा है कि आर्टिफिशियल इंटेलिजेंस और बायोलॉजिकल थेरेपी जब पूरे अपने शबाब पे होगा, पूरे अच्छे से इसको यूज़ किया जाएगा, तो वह रिमेटॉइड आर्थराइटिस के इलाज में एक क्रांति आ जाएगी। मुझे खुशी है कि एक बहुत ही महत्वपूर्ण विषय पर ग्लोबल ऑर्थोपेडिक फोरम और अक्षत सेवा संस्थान और विशेषकर डॉक्टर अमूल्य, डॉक्टर अनिल राम और उनकी पूरी टीम, डॉक्टर झा यहाँ बैठे हैं, कई सीनियर डॉक्टर्स पटना के यहाँ बैठे हुए हैं, डॉक्टर गुप्ता हैं, कई लोगों को मैं व्यक्तिगत रूप से जानता हूँ। लेकिन मेरा ये मानना है कि 2 जगह भगवान न करे जाने का ज़रूरत पड़े, एक तो पुलिस के पास और दूसरा डॉक्टर के पास। लेकिन होता यह है कि उम्र किसी को छोड़ता नहीं है, तो इसका बेस्ट यह है कि हाउ टू प्रिवेंट दीज डिजीज। और जब भी मैं ऐसे ही मेरी अमूल्य से बात होती है तो मैं कहता हूँ कि कुछ ऐसा उपाय बताओ भाई कि आदमी इससे बचे। एक्सरसाइज करना है, जो प्रिवेंटिव एक्सरसाइज जो करना है, क्योंकि अभी ये हमारे नेक्स्ट जनरेशन का एक बहुत बड़ा प्रॉब्लम है, सेडेंट्री लाइफस्टाइल। हम लोग के टाइम में तो हम लोग खेलते थे, मैदान में जाते थे, लेकिन हमारा नेक्स्ट जनरेशन जो है वो खेल कूद से दूर हो गया है। मोस्टली वो सोशल मीडिया, या खेलता भी है तो वो कंप्यूटर पर गेम खेलता है, फिजिकल एक्टिविटी बहुत कम हो गई है। तो मुझे लगता है कि उसकी ओर भी हमें ध्यान देने की ज़रूरत है कि हाउ टू कीप योर बोन्स एंड मसल्स स्ट्रॉन्ग। फिर जो कैल्शियम लोग कहते हैं इंटेक होना चाहिए या वाइटामिन्स का इंटेक होना चाहिए, वो सब तो इम्पोर्टेंट है ही है। तो इस सफल कार्यक्रम के लिए मैं पूरे जो ऑर्गेनाइजिंग कमेटी है उसको बहुत बहुत धन्यवाद देता हूँ, बहुत बहुत बधाई देता हूँ। और विशेष तौर पे जो हमारे राज्य में बाहर के लोग आए हैं, बिहार से बाहर के जो डॉक्टर्स आए हैं, उनका पूरे बिहार सरकार की ओर से मैं पुनः वेलकम करता हूँ। और मुझे आशा है कि आपका बिहार का स्टेप आपको अच्छा लगेगा। और डॉक्टर अमूल्य से भी ये अनुरोध करता हूँ कि मौका लगे तो इन लोगों को आप, जिस अभी मैडम से बात हुई तो उन्होंने नालंदा, राजगीर, बोधगया सब देखा, तो बिहार में अब बहुत सी ऐसी चीज़ें हैं जो नेशनल लेवल, इंटरनेशनल लेवल की चीज़ें बनी हैं। तो वो भी बिहार का एक शोकेस है, राजगीर, बोधगया बिहार का एक शोकेस है। आपको टाइम मिले तो वहाँ भी जाइए, नहीं तो फिर किसी इस घूमने आइए बिहार एक बार। कॉन्फ्रेंस में तो आप आई हैं, एक बार बिहार घूमने आइए। बिहार बदल गया है, बिहार में ऐसी कोई समस्या अब नहीं है, ना सुरक्षा की समस्या है, ना सड़क की समस्या है। तो कम्युनिकेशन ही बहुत अच्छा हो गया है बिहार में, और सिक्योरिटी इन्वायरमेंट भी काफ़ी इम्प्रूव कर गया है बिहार में। तो आपका बिहार में पुनः स्वागत है। और चूंकि ये कार्यक्रम स्वास्थ्य की ओर इंगित है, स्वास्थ्य के भावना से प्रेरित है, तो डॉक्टर्स के लिए मैं ये कहना चाहता हूँ कि एक कोटेशन है कि when all hope is lost, you are the last hope। और इसलिए डॉक्टर्स को शायद चिकित्सक भगवान कहा जाता है। तो आपसे मैं ये कहना चाहता हूँ, एक गीता के श्लोक का हिंदी अनुवाद है, न राज्य की कामना करो, न स्वर्ग की कामना करो, और न ही पुनर्जन्म की कामना करो, परंतु दुख से संतप्त प्राणियों के पीड़ाओं का विनाश हो जाए, बस यही कामना करो। इन्हीं शब्दों के साथ मैं एक बार पुनः आप सभी को बहुत बहुत बधाई देता हूँ, शुभकामनाएं देता हूँ। और विशेष तौर पे डॉक्टर अमूल्य सिंह को, डॉक्टर अनिल राम को और पूरी टीम को जिन्होंने इस प्रोग्राम को ऑर्गेनाइज किया। इसी तरह से आप अच्छे कार्यक्रम करते रहिए और बिहार के लोगों के लिए स्वास्थ्य सेवाओं की एक नई मंजिल आप बनाइए। एक ऐसा उदाहरण आप कंट्री में प्रस्तुत कीजिए कि बिहार हेल्थ केयर में भी काफ़ी आगे जा रहा है। बहुत बहुत धन्यवाद। जय हिंद।
Thank you very much, sir. We are blessed that you have come here at a very short notice, and that's why we wanted to finish this program at 9, because he was busy with our own state administration, sitting at such a high-level post, managing this time. Thank you very much, sir. On behalf of everybody, I will say, especially my guru, Dr. Professor S.S. Jha, Dr. Aarcon, and everybody, because these are the people who have guided us to do something good for Bihar. We are trying to do, and our leaders are there, like you, in the administrative service. Naturally, we are there. So what has come on behalf of Mr. Alok Raj, that this time it is a very short notice, but next time when you do come over, let's give us a chance that we can show you some part of Bihar. We are there as ambassadors of Bihar, I will say, where we can promote our own rich cultural heritage. मैं ज़्यादा समय आप लोगों का नहीं लूँगा, क्योंकि कल फिर सुबह 8 बजे से चाणक्य होटल में ये प्रोग्राम है। कल मौर्य डेलीगेट्स प्लीज डोंट कम टू दिस प्लेस, वी आर देयर एट होटल चाणक्य। थोड़ा सा कंफ्यूजन हुआ है, क्योंकि एट द वेरी लास्ट मोमेंट हम लोग का पहले फैकल्टी डिनर केवल यहाँ था, लेकिन जब मेरे छोटे भाई मनीष ने मुझे बोला कि सर इतने बड़े बड़े लोग आ रहे हैं, इनका कुछ कुछ और लेक्चर्स हम लोग कराए, तो वो स्लॉट बुक था, तो हम लोग बोले कि नहीं, लेट्स हैव अ इवनिंग प्रोग्राम ऑल्सो। तो वहाँ पे चाणक्य वॉज बुक्ड, तो हम लोग यहाँ शिफ्ट किए। दैट्स व्हाई आप लोग को प्रॉब्लम हुई है शिफ्टिंग फ्रॉम दैट प्लेस टू दिस प्लेस, अगेन गोइंग बैक टू दैट प्लेस। बट कल वहाँ से एयरपोर्ट जाना ज़्यादा आसान होगा। इट विल बी अबाउट 10 to 11 मिनट्स या 12 मिनट्स ड्राइव। संडे है तो इसलिए किसी को कोई दिक्कत नहीं होगी। और जब सर हैं तो आप लोग जो बात बोल रहे थे कि एयरपोर्ट के अंदर घुसना, आपको इज्जत से हम लोग पहुंचा देंगे, कोई दिक्कत नहीं होगी। सो वी विल ट्राई टू स्टार्ट एट 8:30 sharp. Please make it a point, all the respected delegates come on time. We will start at 8:30, finish exactly at 2, क्योंकि लास्ट इज अ केस डिस्कशन, पैनल डिस्कशन, वो हम शॉर्ट कर सकते हैं। दैट्स व्हाई आई केप्ट एट दैट अराउंड 45 मिनट्स। होगा ना 15 मिनट का कर लेंगे। इनॉग्रेशन जो भी है, मैं मिसेस शाम्भवी चौधरी कल आ रही हैं, ऑनरेबल MP, she will come at 11:30. तो लेकिन हमारा साइंटिफिक प्रोग्राम इज मोर इम्पॉर्टेंट, वी वांट टू लर्न. और जितने भी डेलीगेट्स हैं, आप लोगों ने बड़े बड़े लोगों की बातें आज सुनी हैं, तो हमेशा लगता होगा कि हमसे ये गलती कैसे हो जाती है. इन लोगों ने बहुत पढ़ाई की है, हम लोग को बहुत सुपरफिशियल नॉलेज है. वी आर नॉट लाइक डॉक्टर प्रोफेसर एस झा जो बहुत इन डेप्थ रिमेटोलॉजी का नॉलेज रखते हैं. सो मिस्टेक्स आर एम्बैरसिंग इन एनीबडीज लाइफ, बट दीज आर द मिस्टेक्स which should be made in your life, which will come as experience, then you will succeed in your future endeavors. This is all that. Sir, thank you very much, sir. इसके बाद इसको वोट ऑफ सर को बहुत अभी नहीं, ये मौका नहीं है क्योंकि हम लोग उसको करेंगे. वी हैव अ सैक्सोफोन सिंगर, सो ही विल प्ले द सैक्सोफोन. डिनर हमारा स्टार्ट हो रहा है. 2 लोग अपना यहाँ पर रह के सैक्सोफोन एंजॉय करना चाहते हैं, दे आर ऑलवेज वेलकम टू बी हियर. और डिनर स्टार्ट करते हैं हम लोग. सो लेट मी थैंक यू ऑल. यू हैव मेड इट अ डे इन स्पाइट ऑफ अ वेरी बैड वेदर. You came right on time. We started right on time. We wanted to finish the scientific program at 9. We did it. And हम लोग का प्लान था 9:30 में डिनर स्टार्ट करने का. मोस्ट ऑफली वी आर ओनली 15 मिनट्स लेट, बट डिनर स्टार्ट हो रहा है कल सुबह चाणक्य होटल में. प्लीज डू कम एट द राइट टाइम.